meetings that we can be in different parts of the world. The Miopia meeting is organized by Foundation Ophthalmology 21, European Miopia Network, and the University of Warmia-Mazury in Poland. Let me say a few words about the European Miopia Network. Main activities include increased public awareness about the risks, prevention methods, and treatment of myopia. We organize educational events such as webinars, also this conference, to share the good practices and promote the latest scientific developments and support the clinical research in the field of myopia prevention and treatment. Now we conduct a few studies. Hopefully we'll be able to present the results quite soon. When you become a member of our group, this is free, no registration fee needed. You will have access to the membership zone, and then you can have access to news, lectures, multimedia, articles, guidelines, recommendations. You can see in the upper part also of this page. We have a great number of experts, European experts from nearly every European country, around 30 myopia experts who create the Council of the European Myopia Network, and also have created a few committees that are again chaired by our colleagues, scientific committee, educational committee, industry relations, international, other societies relations, and social media and committee. We are grateful to our sponsors, which are this year EssilorLuxottica, China, Santen, Oko Foundation, Hoya, Vistel, and Polpharma. We are also grateful to our media patrons. This is the Ophthalmologist magazine and Medycyna Praktyczna. This is the largest medical portal in Poland. Our meeting is very educative, very squeezed. Within the 4 hours, we will provide over 20 lectures, as you see, well, depending on the time zone, but this is shown here at Central European Summer Time. We start at 3 p.m. and we will finish at 7. All these lectures are divided into 2 sessions. Each is finished with a discussion time. We are very happy to have this year Professor Serge Resnikov as the opening lecturer. He is the chair of the International Myopia Institute and a global expert in public health and ophthalmology. He has held leadership roles in the World Health Organization and has been instrumental in developing strategies to combat avoidable blindness and visual impairment worldwide. As an ophthalmologist with a background in epidemiology and public health, Professor Resnikov is committed to advancing equitable access to eye care and fostering international collaboration in vision research. So we are very proud to have the lecture entitled Myopia Prevention and Control. It's time to measure what we do. Please.
Hello, everyone, and thank you for inviting me to take part in this important meeting. I'm Serge Resnikov, and it's a distinct pleasure to be with you today to discuss how it's important to measure what we do in terms of myopia prevention and management. Here is my disclosures that are all related to the International Myopia Institute. And if we discuss myopia from a global perspective, indeed, the first thing is to stress how important it is in terms of number of people that are myope in the world today. It's about 3 billion myopes, which represents roughly 36% of the world population in 2025. And it is expected to grow up to 50% by the year 2050. But it's important also to note that these projections are about 10 years old. So it's interesting to look at to what extent recent data collected through population-based surveys are confirming or not what has been originally predicted. The red line represents what has been currently observed, recently observed, and the blue line represents what was originally expected or predicted. And what you can see on the top left curve, for example, is that it's very similar. So in the Asia-Pacific high-income countries, the predictions and the what has been currently observed are very similar. If you look now on the top right curve, it's about East Asia, so basically China, essentially. And what you can see here is that there is, in the older age groups, what is currently observed is actually below what was originally expected. And this is probably due to the success of cataract surgery, because when a myope is operated, he or she will usually get an intraocular lens that will transform him in an emetropic patient after surgery, although it still carries, of course, the risk of complications. Now, if we look at the high-income countries in Australia, Western Europe, North America, what you can see on the bottom left is that actually what is currently observed is less than what was originally expected. On the other hand, on the right-hand side and the bottom, what you can see here is the situation in Africa, Latin America, and the Caribbean, etc., where actually the original estimations were an underestimation. What is currently observed is above what was expected. This all somehow stresses the fact that in the world today, there are really two completely different situations. The situation in East Asia, where myopia is extremely high, and the rest of the world, where it is existing, of course, increasing, but not at all at the same level. So the world is not uniform in terms of myopia. And this somehow underscores the benefit and the interest of collecting spherical equivalent data in order to build the distributions at the country level, rather than using specific cutoff points, such as, for example, minus 0.5 or minus 0.75, or for high myopia, minus 5 or minus 6. Because if we collect the information as a spherical equivalent distribution, we can calculate the prevalence at any cutoff point as we want, and we can see here also how the situations are actually different in terms of distributions of myopia when we compare the situation in the US, for example, and in South Korea. You can see that in both cases the distribution is skewed, but it's much more skewed in populations where there is a large number of myopes. So please keep remember that the distribution of spherical equivalent is not a normal distribution. So it needs to be expressed in terms of skewness and kurtosis if we want to have an appropriate reflection of the situation. Now, if we go beyond kind of the big numbers, the reason why myopia is considered as a public health issue, it is because of the massive number of incorrect refractive errors, just the people who are myopic but do not have access to the appropriate spectacles that they would need. And this represents something about 150 million myopes that need a correction. And similarly, it is also important in terms of public health because of the significant increase in visual impairment that is due to the complications of myopia, of course, and has been estimated to be about 10 million people living with irreversible visual impairment, especially because of myopic macular degeneration. And this is something that is very similar in terms of magnitude to the visual impairment related to glaucoma and age-related macular degeneration. The problem is that both of these estimates are, again, almost 10 years old. So there is a need to have an update for these estimates based, again, on newly collected data. Because one of the main issues in terms of impact of myopia, in terms of myopia-related visual impairment, that it is not measured as such. It is currently somewhere hidden in the other causes of blindness. This is why it's so important in the surveys looking at the population level of causes of visual impairment to have myopic macular degeneration defined as a specific cause and not just being buried into the other causes of visual impairment and blindness. The good news, of course, is that there are a lot of evidence-based interventions that allow us to prevent and to control myopia. And this is somehow, every day, there are more and more evidence coming. The problem, although, is that all these interventions are not always available and especially not always used. And that's because of lack of training, of course, but also because of different scope of practice, depending on the countries, the involvement of multiple stakeholders that sometimes are not really collaborating in the way they should do, because there are different policies around, and there are also barriers in terms of affordability, because there are many of or most of these interventions usually require out-of-pocket contributions from the patients, which makes that they are actually not always undertaken. And the situation, in addition, varies a lot from country to country. And because of this existing knowledge, it's not the point now is what we need is not only have a better knowledge of what works, but especially we need to scale up the delivery at the country level so that the entire populations are covered. And in that respect, it's clear that individual care is not enough. It requires system level changes, and this only can be achieved through national policies, because only national policies can actually regulate and approve treatments. Only national policy can ensure proper affordability through health insurance covering myopia prevention and control interventions. And only national policies can, of course, coordinate intersectoral activities such as, for example, integration of screening for myopia in schools. In a in a kind of optimal or ideal world, the sequence that needs to be put in place is to recognize myopia as a public health priority. This is the first thing to do. Second, of course, it's about implementing national strategies, both in terms of screening and prevention. The third thing to do is to ensure equitable access to effective interventions. That's again very much about health insurance. But then it's also important to measure the coverage of the interventions that are being implemented, because if we don't know what is happening, we will never know to what extent prevention of myopia is covered among the population, to what extent control of myopia progression is also available within the population. The problem is that so far there is no monitoring framework that has been proposed for myopia. The World Health Organization has done a lot for managing the progress in terms of universal health coverage of refractive errors, but not in terms of myopia prevention and control. So the indicators that are existing at the international level are actually not addressing the issue of myopia properly. And the problem is that if we don't measure what is happening, we actually don't know what is happening. Are we doing the things as we should do them? Are we doing enough, etc.? And these indicators would be necessary to track the progress, particularly to see what is working in the real world, because one thing is to have RCTs, another thing is to be sure that this is actually working in the real world. And this requires standardized indicators. And it's important to keep in mind that there are many different kind of indicators, but there are really two kind of indicators, I think, that are particularly relevant when it's about myopia. It's the outcome indicators. That means what are the effect on the health status, and this is especially things like this spherical equivalent refraction, as we mentioned, the actual lengths, the complications, the occurrence of complications, etc. But there are also process indicators that are very important, because these indicators would help us to track what is actually being done, and this refers especially to policies and activities. To give you a few examples of the possible process indicators, one possible indicators would be to track the outdoor time policies in school and preschool children, whether they exist or they don't exist. And then if they exist, what is the coverage? What is the percentage of the population that is covered by these policies? Another possible process indicator is to measure the percentage of children spending at least 2 hours a day outdoors, for example. Another process indicators would be to track the reimbursement of myopia control intervention, that exist or not. And if they existed, what is the percentage of the population that are benefiting from this kind of reimbursement? Then another possible process indicator is to look at the percentage of progressing myopes that are actually benefiting from myopia control intervention. So all these kind of things could be implemented, especially in places where there is a functioning health system, like in high and middle income countries. Then sometimes it is good to set some targets, because this is a way to boost public health action. If you say that, for example, by the year 2040, high myopia, to be defined, prevalence should be below a certain threshold in young adults. Or you could also have like a target regarding the visual impairment due to pathological myopia that should be below a certain percentage or per 100,000 people population. Or to have below a certain percentage of total visual impairment in adult 50 plus that is related to myopia. All these kind of targets would help particularly from a public health perspective, to mobilize resources. And actually, some countries, for example, in China, they have already set that kind of targets. Last, but not the least, to conclude, I think it's important to keep in mind that time is of essence. There is no way that we should waste time in terms of myopia prevention and control, because even if the incidence of high myopia were decreased dramatically overnight, the burden of the pathological myopia will persist for decades. Because the existing cohorts of myopic children and the existing myopes will carry their risk throughout their life. They are here. They already became myopic. They already have their risk related to that. And whatever we do now is not going to reverse that. So this is why, at least, it's so important that we reduce the incidence of high myopia, particularly as soon as possible. Thank you for your attention, and thank you again for the invitation and the privilege to talking to you all. Thank you.
Good afternoon, everybody, and thank you for the invitation and the possibility for us to share with you our investigations on the possible effects of induced higher-order aberrations on myopia control by orthokeratology. We have started this series of investigations many years ago, and actually it was 2005. And first part of this investigation was to see the patients, teenagers who have been practicing orthokeratology for myopia correction. And we were able to follow for 4 years the group of teenagers, 1,200 of them. And as a control group, we had nearly 150 teenagers who used glasses and contact lenses for correction of myopia. You see, both groups were the same in age and in the degree of myopia. And first part of our investigation, we realized that in 4 years, the majority of the teenagers who used glasses and contact lenses, actually nearly 90% of them, they had the progression of myopia for over half dioptry per year. And on the contrary, the teenagers who practiced orthokeratology for myopia correction, they had stable or very slow progression of myopia for less than half diopter per year. So we decided to see what's the difference between these two groups, and knowing the idea of Professor Avitisov that the progression of, actually the onset and progression of myopia in teenagers is a reaction to insufficiency of ciliary muscle, we checked these two groups from this point of view, and we realized that really the strength or the workability of ciliary muscle of the patients with orthokeratology at this time of this correction increased more than twice. So the second part, we decided that we will see what's the difference between the two groups of teenagers who were with orthokeratology correction. I mean, the group of nearly 30% of those patients who really progressed at the time of orthokeratology. Comparing these two groups, we realized that the workability or the strength of the ciliary muscles really increased in the group of patients with the stable or slowly progressing myopia. The next part of the investigation was to see what could be the effects or how the higher order aberrations of the patients are changing at the time of orthokeratology, because we know that the flattening of the central part of the cornea is inevitably increase the level of spherical aberrations. And we have checked the patients from this point of view, and we saw that the general level of higher order aberrations at the time of orthokeratology, it's increasing about 3 times. But if to see the spherical aberrations separately, the level of spherical aberrations at the time of orthokeratology treatment is increasing about 10 times. So all the induced spherical aberrations were positive. So how this level of spherical aberrations are influencing the eye? We found the answer in the work of Alfredo Amiga and his colleagues, who were investigating the possibility of presbyopia correction by laser vision correction. And they realized that if the patient with the myopia had conventional laser correction, they are gaining the increasing number of spherical aberrations, and these spherical aberrations are influencing the refraction of the eye, moving it towards emetropia. At the same time, if the pupil constricts and the iris is blocking peripheral part of the, or paracentral part of the cornea, and the level of spherical aberrations is decreasing, the focus of this eye is shifting towards hyperopia. We checked our patients from this point of view, and we have the possibility with our aberrometer not only see the entire level of aberrations or spherical aberrations separately. There is a protocol that can compare the level of aberrations and the refraction of the eye versus pupil size. How the pupil size influence the refraction of the eye. And if to see the eyes, this is the eye of the patient with the orthokeratology, before the orthokeratology treatment, you see the myopia is about 2 minus 2.5. But if to see the refraction of this patient, we can see that it is not changing when the pupil is changing from 7 millimeters to 3 millimeters. But if to see the eye of the patient corrected by orthokeratology, we can see that, first of all, the increased number of aberrations, and the punctum sphericus function is absolutely different. The level of aberrations is much higher. But if to see the same protocol, the refraction of this eye versus pupil size, we can see that in reality, the emetropic refraction plus minus a quarter of dioptry is when the pupil is between 3.5 to 4.5 millimeters. If the diameter of the pupil is increasing with the dilation of the pupil, the refraction of this patient is shifting towards myopia. But if the pupil is constricting to 3 and less millimeters, the refraction is shifting towards hyperopia. So we know that the pupil miosis is the part of the accommodation. With this, whenever the patient is accommodating, his refraction is shifting towards hyperopia. It means that every time this patient is accommodating, his muscles have to overcome this hypermetropization. So they have to work harder for accommodation to see clear in close distance. So we checked our patients from this point of view, and we had the group of nearly 60 patients, nearly 220 eyes, and all of those patients, they had stable emetropic refraction at the time of the orthokeratology treatment. But if to see the changing of refraction versus pupil size, we saw that when the pupil is constricting to 3 and less millimeters, the refraction of those eyes is shifting towards hyperopia. And with the dilatation, the refraction is shifting towards myopia. All the patients in this group, they had stable refraction. They have increased of walkability of ciliary muscles and stable axial length of the eyes. So here I want to make some, let's say, statement regarding the theory of peripheral retinal defocus that plays role in the effect of myopia control at the time of orthokeratology. We're speaking about the same effect, but we're not separating the central cornea and the paracentral cornea and the central focus and peripheral focus, but we're looking at this effect from the point of view of spherical aberrations. And actually, the dynamic refraction, dynamic pupil-dependent refraction of those eyes. So we had multifactorial analysis, and we realized that we have very strong connection between the delta of refraction versus pupil size, the changing of refraction of the patients versus pupil size, and we had strong negative connection of absolute figures of accommodative reserve, workability of ciliary muscles, and the actual length of the eyes. The stronger are the ciliary muscles, the less is the changing of actual length of the eye. We have strong negative connection of the delta of accommodative reserve and actual length. More than this, all those effects, they are stronger in the young patients groups. So with this, we had the possibility to do several conclusions. The first, that in case of stable corrective effect, or orthokeratology can have a preventive effect too, means myopia control. The increased level of positive spherical aberrations is responsible for the dynamic pupil-dependent refraction of the eye, shifting it to hyperopia with the meiosis. And with this, the ciliary muscles have to work harder to see clear in close distance, and shifting the refraction towards myopia with the dilated pupil. And preventive effect of myopia control in teenagers is associated with the significant increase of ciliary muscle workability and can be explained by it. More than this, we had another conclusion that is based on this results, that all those effects are more significant in younger patients group. Means that if we're speaking not only about myopia correction by orthokeratology, but of preventive effect of or myopia control, we have to start earlier. Age 9, 10, 11 years are ideal. It's ideal to start orthokeratology if we're thinking about myopia control. And thank you very much, and hope I will be able to join you online for questions and answers. Thank you.
Hi everyone, I'm very thrilled to be here today. My talk is called Indications of Favorable Structural Changes During Auto-K Treatment. I have no financial disclosures. I have participated in an advisory board meeting hosted by Santen. I think for everyone who does myopia control, the main aim is myopia control beneficial in terms of reducing the risk of pathological myopia? Let's first talk briefly about the characteristics of myopic eye growth. Well, the axial growth outpaces the growth of the corneal diameter. Also, the choroidal thickness decreases or increases less during childhood. My group had these questions. What happens to the relationship between the corneal diameter and the axial length during Auto-K treatment? And we chose to use the corneal diameter as a pseudo measure of equatorial growth. Also, what happens to the choroidal thickness before and during Auto-K treatment? And thirdly, what happens to the retinal thickness before and during Auto-K treatment? I'm going to present to you two different studies and results. And the first one, in order to look at the corneal diameter and the actual length, this was a sub-study of the control study. And the control study was a one-to-one randomized clinical trial where we included 60 children. The duration of the study was 18 months. We included children with ages 6 to 12 years and myopia 0.5 to 4.75 diopters of spherical equivalent. And as you see here, the children were randomized one-to-one to either Auto-K, which is also called keratology lenses, and to single vision spectacles. For this sub-study, 41 participants were eligible, and we used the lens star to measure axial length and corneal diameter. And currently the paper is under review. So at baseline, we found that the relationship between the corneal diameter, which is shown on the y-axis, and the axial length, shown on the x-axis, are similar in both groups. And what I'm going to do now is put in here the 18-month results, and what you see is that for the single vision spectacle group at 18-month follow-up, the green line, it was similar to the baseline slopes for both groups. However, the Auto-K group differed significantly at 18-month follow-up. To look at the choroidal and the retinal thickness, we had a different design, because when the 18-month follow-up was approached in the control study, we asked the participant if they wanted to continue into the control 2 study. And what we did was that we had the Auto-K group continue the treatment for another 18 months, whereas the group that used single vision spectacles in the beginning were crossed over to Auto-K treatment. So for this study, we're just looking at this arm here. That was initially the control arm, and that was crossed over to Auto-K treatment. For this study, we therefore only had 20 participants, and we used the pre-treatment period, the last 6 months of that, and also the treatment period, which was 18 months. We used the SS-OCT Triton, and we used 7 × 7 millimeter 3D macular scans. We averaged the thickness of all ETDRS subfields, and the choroidal thickness was adjusted for acquisition time of day, and all thickness measures were adjusted for ocular magnification. Regarding the choroidal thickness, what we saw was that there was a tendency that the thickness decreased from the pre-treatment visit, that's the one indicated by minus 180, compared to the day 0, where the treatment was initiated. However, this was not statistically significant. Then we compared the treatment period, where we compared the day 0 with the follow-up after treatment initiation. And what we saw was that the choroidal thickness increased significantly, pretty fast, and at day 30 that was significant. There was a small drop at 1 year follow-up where the thickness change was not significant, but it increased again for the 18 months follow-up. We saw similar things with the retinal thickness. There was a significant decrease during the pre-treatment period, and also the retinal thickness increased significantly. It didn't increase as fast. It was significant at the 90 days follow-up, and then there was a drop at the 1 year follow-up at 365 days, and we don't have an explanation for that. But it increased again at the 18 months follow-up. So, to conclude, the correlation between the axial length and the corneal diameter changed significantly in children who used Auto-K compared to children who used single vision spectacles. In the crossover study, we saw that the retinal and the choroidal thickness seemed to decrease during the observation period, and during the treatment period, the retinal and choroidal thickness increased. So because these are secondary outcomes, these are hypothesis generating. And the hypothesis that we have been thinking about is that AutoK modifies the retina and the choroid. There must be something going on since the thicknesses are changes. Also, if the corneal diameter can be used as a pseudo measure for equatorial eye growth, these data suggest that the outpacing of the actual growth compared to the equatorial growth is reduced in children using AutoK compared to children using single vision spectacles. So if this is actually the case, and if the changes in this correlation can be used, it must mean that something is going on in the sclera as well. And it seems that the growth trajectory changes towards a more symmetrical eye growth. And the question is, could this be protective against pathologic myopia? There are perspectives and there are things that we still need to investigate. So next step could be to examine structural changes in the retina and the choroid, to find optimal methods to evaluate growth trajectories, to investigate if defocused spectacles initiate similar growth trajectories. So I think this is all very exciting, and I hope for many more answers in the future. Thank you very much.
Dear colleagues, I would like to share our 20-year clinical experience with orthokeratology, focusing on efficacy, safety, and predictors of myopia progression. Orthokeratology was introduced at our department in 2005. Initially, we used mainly for adults as an alternative to refractive laser surgery. However, there was a gradual shift over time due to increasing clinical experience, growing international evidence, and the focus shifted toward myopia control in children. So as a result, patient numbers increased significantly. Nearly 700 treatments have been performed over 20 years. We had local relevance because in Hungary there is a high participation in water sports because the Hungarian national water polo team and the Hungarian swimmers are multiple Olympic champions. And the lens-free daytime vision is really practical in water sports. The aim of the presentation is to evaluate the long-term efficacy of orthokeratology in myopia control, to analyze factors influencing axial elongation, to assess safety and inflammatory complications, and to identify clinical risk factors for adverse events. To examine the axial length progression, we conducted a retrospective cohort study including 100 myopic children with at least 5 years follow-up using Paragon corneal reshaping therapy. The axial length was measured annually by the same optical biometers and statistical analyses were performed. Here you can see the baseline demographic and clinical characteristics of the study population. There was a little bit more male than female, and we selected the age group which is most sensitive to myopia progression. Our results showed that the mean annual axial elongation remained low and stable over time with no sign of treatment fatigue, showing an annualized rate of 0.07 mm per year. This table shows our results in comparison with previously published European data. Since there was a large variation in the follow-up period and the axial length in the European data, we converted the European studies to a common metric of annualized axial elongation. And as you see, we had a better long-term treatment response compared with previously reported European data. To analyze factors influencing the axial length elongation, baseline age showed a strong negative association with the axial length progression over the 5-year period, indicating that younger children demonstrated greater axial elongation than older children. There was a clear separation between the youngest and the oldest age group at the age of 11 and 12. So younger age was associated with faster progression during orthokeratology treatment. Higher progression was observed in girls than the boys. However, this difference was not statistically significant. So no sex differences were observed in orthokeratology treatment. The baseline spherical equivalent was significantly associated with the 2-year axial elongation. So children with higher baseline myopia showed less axial elongation during the treatment, however, just in the first 2 years. The significance was lost during the 5-year follow-up. So a higher baseline myopia was associated with slower early progression. The first-year axial elongation was strongly associated with the 5-year axial length change, and even stronger association was observed between the 3 and 5-year axial length changes, which means that the first-year treatment response is a clinically strong predictor of long-term orthokeratology outcomes. A responder analysis was also performed. Responder was defined as a participant with axial elongation less than 0.125 millimeter per year. How was it calculated? So the average axial elongation in myopic children is between 0.2 and 0.3, so we can say 0.25. And we know that orthokeratology has a 50% reduction effect. That's why we choose this millimeter. And as you can see, we have only 17 children and 29 eyes who were non-responders. So we can say that our cohort showed a high treatment response rate. Now let's move on to safety. To assess safety, we analyzed a larger cohort of 600 patients over a 20-year period. All keratitis cases were recorded, and potential risk factors were evaluated using logistic regression analysis. From safety perspective, no cases of macrobial keratitis were observed. However, infiltrative keratitis occurred in about 21%, mostly within the first 2 years. Infiltrative keratitis is a sterile keratitis due to a hypersensitivity reaction. The risk factors for infiltrative keratitis we identified were water sports, meibomian gland dysfunction, and higher baseline myopia. Let's now look at these factors in more detail, starting with water sports. So individuals engaged in water sports were 3.8 times more likely to develop infiltrative keratitis compared with those who were not. The possible explanation could be that the exposure to pool chemicals during the day and disinfectant solutions at night may continuously irritate the ocular surface, induce a hypersensitivity reaction leading to epithelial alterations. And the solution is a solution. Yes, because in cases of infiltrative keratitis, we switched to peroxide system. No further inflammatory events occurred. Meibomian gland dysfunction had a 6.8-fold increased risk of infiltrative keratitis relative to those without MGD. The possible explanation could be that an increased bacterial load leads to a higher level of bacterial enzymes, promoting the release of inflammatory mediators and triggering inflammatory response on the ocular surface, especially if it's combined with the multipurpose solutions. We also found that higher baseline myopia was associated with an increased risk of infiltrative keratitis. The risk doubles every 3 diopters. The possible explanation could be that greater lens-induced mechanical stress and epithelial disruption may increase susceptibility to inflammation. We didn't find any significant association between the age, sex, and the history of allergy. So in conclusion, orthokeratology provides sustained long-term control with no evidence of treatment fatigue. Consider earlier intervention, especially younger children, could be important as younger age was associated with faster progression. The first-year response is useful for predicting the long-term efficacy of a treatment. In case of meibomian gland dysfunction, water sports, it is advisable to use a peroxide system instead of multipurpose solution, even though the enzymatic cleaning process is more complicated. With higher initial diopters, extra attention is needed. Thank you for your attention.
My name is Mary Day, and today I'll be presenting on the evaluation of methods and the success of optical interventions in a real-world population. This study was done in conjunction with Dr. Stephanie Kearney, and the data presented today has actually just been accepted for publication in Optometry and Vision Science. Optical myopia control interventions available in the UK include specialised spectacle lenses and various contact lenses. Clinical trials found that the mean reduction in progression for these interventions is equivalent to 0.24 diopters per year and 0.13 millimetres per year. The results from clinical trials may not directly translate to a more diverse clinical population, and therefore it's important to study the effectiveness in a clinical population. There have been a handful of studies reporting the effectiveness in clinical populations in Europe and China, but they look at myopia spectacle lens interventions only, not evaluating a change in progression rate. In the UK, there's one published case series using a variety of methods to investigate the effectiveness of the intervention, but this is limited by its small sample size. The purpose of this study then is to expand the previous case series using improved methods to provide a more robust evaluation of the success of optical myopia control interventions in real-life patients within a UK clinic setting. And the aim of this study is also to explore the methods for evaluating successive myopia control interventions. We did this by extracting data from patient clinic records here at Glasgow Caledonian University in Scotland. This included 64 children, or 120 eyes, and the majority of them were white. We used various methods within this study, but today I'll tell you about the 3 main methods. The SAR change method calculates the SAR change between before and during an intervention. Here we're assuming that the rate before intervention would continue during the period of the intervention had the child not worn the intervention. So it calculates the rate predicted without the intervention and takes the difference between that and the rate during intervention to calculate the SAR change. To determine whether an intervention is successful, we compare that SAR change that I've just described with a target value. There are various possibilities for this value, and we have used an 050 change in previous studies, but after exploring the precision of the measurement, In this study, we decided that the best value is the precision of the measure, which is 0.82 diopters. When exploring these methods, we can say that the advantages are that it uses SER, which is easily usable by eye care practitioners. It also individualises these values to the child. The disadvantages are that it doesn't account for the potential of a reduction in SER progression, which happens naturally slowing with age, and SER is less accurate than axial length. The second method is the axial length change method. This predicts the rate of progression had the child not used an intervention. It does this using the pre-intervention axial length rate, and it adjusts this by a slowing factor for age. You can see this in the example here. The axial length change is the difference between the predicted rate and the actual rate that the child achieved during the intervention. In order to determine if an intervention is successful, the axial length change is compared with a target value. As the precision of the axial length measurement is 0.06 millimeters, the absolute reduction from the clinical trials, which is larger than the precision of the measure, can be used. The clinical trial value was selected depending on the intervention type that the child was using and the duration of their use. For example, if a child was using MySight for up to 2 years, then 0.08 would be chosen as the target value. When evaluating the axial length change method, we can see that the advantages are that it uses axial length, which is more accurate than SER. The method's individualised to that individual child, and the method accounts for the potential of a reduction in axial length progression as the child ages. The disadvantages are that not many people in practice have the ability to measure axial length. It's also important to note that this method requires monitoring of the axial length before starting the intervention. The benefit of that is that it helps us to confirm the presence of axial myopia and the presence of myopia-related axial length progression, which is important because this is what the interventions are aimed at. The risk on the other side is that the SER and axial length are likely to progress during this monitoring period. Thirdly is the emmetropic growth method. This method compares the axial length rate during the intervention with the target value, which in this case is the axial length rate of an emmetrope of the same age. Advantages of this method is that it uses axial length rather than SER. It's also quite useful in practice when discussing the concept of a normal versus a myopic eye growth with patients. The disadvantages are, and you can see this from the graph here, that comparing with an emmetrope seems a bit overambitious given they have a longer axial length to start off with. And it doesn't take into account any pre-intervention rates. And this would underestimate success in those with a fast rate of progression and overestimate it in those with a slower rate. Show that there is a significant reduction in SER and axial length rates during intervention. This is shown by the coloured bars on the graphs versus what was predicted to happen in the patient without an intervention, and that's the grey bars. There's no significant effect of the intervention type on the axial length or SER rates. The large error bars seen in the graph show the large variability between subjects. This slide shows the results in terms of treatment success. Across the methods to assess success, 33% of eyes had a successful outcome and 32% obtained the mean axial length reduction rate from equivalent clinical trials. Regression models were used to assess factors for prediction of success, and this was significant for the axial length change method only. For this regression, a faster axial length rate pre-intervention was the only significant predictor of a larger axial length reduction. The other factors included in the regression are listed in the slide below. In conclusion, this study evaluated various methods to determine the success of optical myopia control interventions, and the axial length change method is likely to be the best method currently available for evaluating success in the individual child. This study found that measuring the pre-intervention axial length rate may be useful in predicting the axial length change that occurs as a result of the intervention. And as we're talking about measuring the axial length rate before a child is in an intervention, the benefits of this monitoring should be weighed up against the amount of progression that could occur during this monitoring period, and that should occur as a part of a balanced discussion with the child or carer. We also conclude that about 1 in 3 children had a successful intervention, and there was significant variability in the results between individuals. These results should be discussed with those considering the use of myopia control interventions alongside the reduction values found by clinical trials, and this will help inform balanced discussions about the risks and benefits of myopia control interventions. And with that, I would like to thank you for listening.
Good morning, my name is Pilar Merino and I don't have any conflict of interest. I'm going to talk about strabismus and myopia, and we have to differentiate between high myopia, where there is an axial length more than 26.5 millimeters and refractive error more than 7 diopters, and low myopia. Strabismus in highly myopic patients represents a 15%. And since 1997, we know that there is a nasal displacement of the superior rectus and a lateral rectus inferior displacement, according to the magnetic MRI coronal studies. And there is a dislocation of the superior temporal area of the glove due to rupture of the elastic band between superior and lateral rectus, causing isotropia and hypotropia known as heavy eye, with a limitation of adduction and supradduction. But there are other characteristics, as for example, the complex isotropia with hypertropia that represents an exception to Yamaguchi's theory, where eyeball prolapse occurs in areas without muscle coverage, or exotropia with hypo or hypertropia, small horizontal deviations and small vertical deviations known as sagittal eye myopia. The indications for orbital MRI is considered advisable in cases with only vertical deviations, but not essential because clinical and intraoperative findings allow surgical indication, as we can see here, an infradisplacement of the lateral rectus. But MRI helps differentiate between heavy and sagittal and no eye syndrome. In heavy eye, the mean angle between superior and lateral rectus is 121 degrees, and in sagittal eye myopia, the mean angle between superior and lateral rectus is 104 degrees, with lower displacement of the lateral rectus without medial displacement of the superior rectus. About surgical treatment, strabismus in high myopia is always a great therapeutic challenge to be faced by the strabismus specialist with several surgical techniques, and we have to do an individualized treatment. The type of procedure depends on the magnitude and the type of deviation, the limitation of adduction. We have to do a large recession of medial recti, but we have to avoid large lateral rectus recession. Yokoyama technique is a technique described to correct glove herniation between superior and lateral rectus in highly myopic patients with isotropia and hypotropia, repositioning the glove within the muscle cone. In this video, I am doing this technique with topical anesthesia and sedation. And I'm going to isolate the bellies of the lateral rectus and the superior rectus, and I am going to join both bellies. If I only want to join both bellies, I can use non-absorbable suture as the Chrome 5.0. But if I want to fixate to sclera, I have to use absorbable suture by Krill 6.0. But I prefer not to fix to the sclera because of the risk of perforation due to the thin sclera in highly myopic patients. Yokoyama technique corrects about 25-30 presence diopters of isotropia and more than 12 PD of hypotropia. So, in cases where there is vertical deviation less than 12 PD and horizontal deviation less, no isotropia, but exotropia, or no horizontal deviation, I don't recommend to use the Yokoyama technique because we are going to have an overcorrection. In this case, a heavy eye, left heavy eye with a high myopia patient, I did a Yokoyama technique joining the superior and lateral rectus associated to a medial rectus recession of 8 mm, obtaining a good outcome not only in primary position but improving the abduction and supraabduction. In cases with saging eye high myopia, we have to employ the supraplacement of the lateral rectus, as we can see here in this figure. And I'm going to reposition the belly of the lateral rectus. I can use this technique in cases with hypotropia less than 12 PD, using absorbable suture with Picryl 6.0, and in my experience, correct about 8 PD of hypotropia without affecting the horizontal deviation. So there are several surgical techniques in high myopia: Yokoyama, lateral rectus myopecia, medial rectus recession, and in the second surgical time, we can do an inferior rectus operation in the event of under or overcorrections. There is another type of strabismus associated to simple myopia, that is acute acquired comitant isotropia. It was considered a rare type of strabismus with a low prevalence, with different sociopathogenic mechanisms involved, that begins late in childhood, adolescence, or adulthood after development of binocular vision. The characteristics are anisotropia of equal magnitude at distant and near in primary gaze and other positions, with differences less than 5 PD, and it may be associated with constant or intermittent diplopia that progressively gets worse. In the classical classification of this type of strabismus, the type 3 or Wilczewski would be associated to myopia more than 3 diopters and corrected. In the last decade, it has been linked to the excessive use of smartphones or tablets. The time is not defined. And according to Wilczewski theory, myopia patients who perform excessive near work without refractive correction have increased tension on medial rectus, causing this type of strabismus. My updated etiology would be excessive use of tablets and mobile phones, microstrabismus and isophorias decompensated, myopia, and neurological diseases. The neurological assessment is considered advisable, except in cases without previous history of strabismus, occlusion, or amblyopia. Although intracranial pathology occurs rarely, this cause cannot be left out due to severity and need for urgent treatment, and up to 10% of the cases have cranial diseases. What about refraction? It's different depending on the age, but over 18 years of age is frequent the moderate and high myopia. The therapeutic approach is, first of all, try to reduce near work, but it's very difficult to get. In some cases, with this type of strabismus, restricting near work might improve, but it is not yet clear in which cases these improvements are achieved, preferably with good stereosis and small angle strabismus according to the literature. Cycloplegia is not recommended except for spasms of accommodation. And my preferred treatment would be surgical treatment with monocular or binocular surgery. Botulinum toxin is indicated in the literature in deviation less than 15 PD, needing several injections. And the PRINCE would be only a temporal message waiting for the neurological assessment completed. My take-home message would be extraocular muscle surgery is an excellent treatment. Isophorias and microstrabismus accounted for almost half of the cases, and excessive use of tablets and smartphones represented 1/2 of our sample, but almost all subjects had myopia. Many thanks for your invitations.
Good morning, everyone. My name is Sylwia Kijewska, and I am Product Manager at Hoyalens Poland. Today, I will present the latest clinical evidence for Miosmart IQ, our newest solution for progressive myopia, focusing on the results of a 12-month randomized controlled trial and how this innovation raises the bar in myopia control. Miosmart IQ builds on our proven DIMS technology, but with a refined design that lets us target the near peripheral retina even more effectively. To do this, we've enhanced three key aspects of the optical layout. First, we extended the treatment coverage by adding more defocus segments, ensuring that child's peripheral visual field receives a broad and consistent myopic defocus signal, even when wearing larger frames. We also made the signal more powerful by increasing the defocus power of the treatment segments from 3.5 diopters to 4.5 diopters, delivering a stronger myopic defocus stimulus where it is most needed. Finally, we activated the treatment zone by reducing the clear central area from 9.4 millimeters to 6.9 millimeters, bringing the defocus segments closer to the center of the lens. This positioning is intended to continuously stimulate the near peripheral retina, the region most responsive to myopic defocus. Together, these refinements elevate the original DIMS design and strengthen the treatment effects of Miosmart IQ. Of course, before bringing Miosmart IQ to the market, we went through a complete clinical development pathway to ensure that the new design is not only safe and effective, but also delivers the level of performance children truly need. We started with phase 1, focusing purely on safety. We tested the new design on a small group of children to assess visual tolerance and adaptation, and everything was reassuring. Across all parameters, there are no significant differences between Miosmart, Miosmart IQ, and single vision. Then, in phase 2, with the larger group, we looked at both safety and early effectiveness. We monitored choroidal thickness changes, which is a useful short-term biomarker to understand the early response to myopia control. After only 2 weeks, choroidal thickness increased by more than 15 microns compared to the control eye. And what's especially interesting is that this early increase over 2 weeks is comparable to the change observed with Miosmart over the first 3 months. These findings, along with phase 1, were presented at ARVO 2025. With phases 1 and 2 validated, we moved into a full randomized control trial. Because of regulatory requirements, the study includes 3 arms: single vision, DIMS spectacle lenses, and DIMS TED spectacle lenses, allowing us to compare the new generation to both standard of care and Gen 1. And the results were presented during ARVO 2026. Let's now focus on the detailed results of 12-month RCT. This was a prospective double-mask randomized clinical trial conducted at the Hong Kong Polytechnic University. The aim was to test the efficacy of the novel dim-stat lenses compared with single vision and dimmed lenses. The study included 202 myopic children aged 4 to 12 years. Participants were randomized into 3 groups: single vision, MyoSmart, and MyoSmart IQ. Importantly, children had documented myopia progression or early onset of myopia prior to enrollment, making this a clinically relevant, high-risk population. For the younger group, inclusion criteria was early onset myopia, defined as myopia present in at least one eye with minus 0.75 diopters at age 4 to 5 or minus 125 diopters at age 6. For older group, it was required to have documented progression of spherical equivalent of minus 0.5 diopters or more per year, or axial elongation more than 0.27 millimeters per year. Out of more than 700 initially screened participants, 202 children were randomized. After exclusions and follow-up, each group maintained comparable sample sizes. This ensures robust and reliable clinical comparisons across all 3 designs. At baseline, there were no statistically significant differences between the groups in age, gender, refractive error, or axial length. This is critical because it confirms that any differences observed later are due to the treatment effect and not baseline bias. After 12 months, visual performance was assessed, and the key takeaway: there were no clinically meaningful differences between the 3 lens groups. Distance and near visual acuity, accommodation, and binocular function remain comparable. This confirms that MyoSmart IQ maintains good visual quality and comfort for children. Similarly, reported visual symptoms such as blur, glare, or discomfort were comparable between MyoSmart, MyoSmart IQ, and single vision group. This indicates that the new design enhancements do not negatively impact patients' experience. Now, to the most important outcomes. After 12 months, with MyoSmart IQ, the change in spherical equivalent after cycloplegia was plus 0.046 diopter, meaning there was no myopia progression in spherical equivalent on average. And importantly, minimal axial elongation with 0.075 millimeters on average, meaning very limited eye growth in the whole group. Both outcomes were statistically significant compared to single vision lenses. This demonstrates strong clinical efficacy in controlling myopia progression. When analyzing different age groups with cycloplegic spherical equivalent, for children aged 7 to 12, MyoSmart IQ showed over 100% efficacy. In even younger children, aged 4 to 6, we see meaningful treatment effect with significant reduction in progression. This confirms effectiveness across a broad pediatric population. Looking at axial length, MyoSmart IQ shows near zero axial elongation in older children. And in younger children, there is still a strong reduction in eye growth. These findings are consistent with the refractive results that we just discussed and reinforce the biological impact of the treatment. Children wore lenses on average more than 13 hours per day, with no differences between groups. And regarding safety, only 3 device-related events were reported, all mild and resolved within 2 months. Worth noting that no event was related to MyoSmart IQ. To summarize what we've just seen in the data. First, no myopia progression on average with MyoSmart IQ in the first 12 months of wear in children aged 4 to 12. Second, minimal eye growth on average with MyoSmart IQ in the first 12 months of wear in children aged 4 to 12. And third, MyoSmart IQ is Hoya's first spectacle lens with reported clinical evidence for effective control of myopia progression from age of 4 years as a monotherapy. So now we are at the launch of MyoSmart IQ to different markets. This is where we observe day-to-day wear and clinical adoption, and practitioners interested in contributing are very welcome. So you can see that MyoSmart IQ is not only patient-centric, it is clinically validated step by step with a solid and transparent development process. Thank you very much for your attention.
A warm welcome from my side. It is a great honor for me to be part of this symposium and to speak about the clinical workflow implementation of our myopia management practice. My name is Max Arikocki. I am an optometrist based in Innsbruck, Austria, where I work alongside my ophthalmological colleagues at the Eye Center Kettenbrücke. We are a full spectrum ophthalmological clinic with a keen interest in lifelong myopia care. Our myopia clinic follows a 4-pillar approach in which I am responsible for pillar 1, the pediatric myopia management. For our adult patients, we have pillar 2, the conservative treatment of the myopia in our contact lens department or with glass prescription. And for our patients that seek a operative treatment, we have our refractive surgery department where we can perform every operation from laser to ICL implantations. Pillar 4 is for our myopic patients later in life. If they have myopia related complications, our surgeons can try to do their best to restore the vision in our surgery department. Clinical work days are packed with patients and are really busy. Therefore, the implementation of workflows is really crucial to maintain a high medical quality. And I'm pleased to share you our approach to myopia management. When children and their parents come to see us, they need to fill out a registration form, which is then digitalized by our medical assistants. It contains basically all the general information, medical and general health status. In the meantime, we have a myopia management information running on our television in the waiting room to already raise awareness to this topic. The medical assistants will then conduct a native autorefractometer measurement and a tonometry measurement, and the patients are then sent into the optometry department. Once the patients are in the optometry department, a refined myopia-specific anamnesis is conducted. We test for the native visual acuity as a next step because we want to have a baseline measurement for the consultation. This also often helps us to put the refraction values that we later get into context. We then gain a lot of myopia relevant information by using our combination device, the Pentacam AXR Wave, where we provide or are provided with information about aberrometry, pupillography, axial length and topography. After that, a dry retinoscopy is performed to have a baseline measurement for the subjective refraction. We do want to keep the eye at a native state at this moment as we double check binocular vision after the subjective refraction, and we do not want to have falsified results by the cycler. After that, the anterior segment is screened, and if everything looks fine, we can add the drops of tropicamide for the cyclo. We do 1 drop, wait 5 minutes and add another one. So as all relevant parameters are mostly known by that time, we use the time frame until we have the full cyclomidriatic effect already for our myopia management consultation. In this time frame, we discuss percentile curves, we show the patients, we explain them what myopia management is and why myopia should be treated and corrected at the same time. We show them the eye model and walk them through their individual myopia report. After the 20 minutes, our medical assistants reperforms the autorefractometer measurements and sends the patients back into the optometry department, where we refine the refraction with the retinoscope and the subjective refraction. This is a really important step because we want to make sure that we don't have any accommodative parameters that falsify our refraction. After that, the risk profile of the patient is finalized, and based on that, we assess the treatment and follow-up plans. After the optometry department, the patient sees the ophthalmological unit, where a refined medical anamnesis is performed at first, and then a medical assessment of the anterior and posterior segment is conducted. After these findings, our medical assistants do all the documentations, and after that, future appointments are coordinated with the patients and the parents. We implemented evidence-based myopia management in our practice. Therefore, also the clinical decision-making follows a rigorous part. We have created our own risk assessment, which is the base for our clinical decision-making. Once a myopia is psychoplegically confirmed in our setting, we add the individual risk factors to the profile. The points next to the individual risk factors will be added together and will then form the classifications. As individual risk factors, we take age and axial length as one of the strongest predictors for a high-risk progressive myopia. But we also consider daylight exposure, new work, parental myopia, and binocular vision. The score is then added together and form the 4 different categories. In high-risk patients, we start with a dual treatment approach right from the start, meaning low-dose atropine added with an optical component as contact lenses or defocusing contact lenses. Patient with a significant risk profile will start with the monotherapy, and patient with a moderate to low risk profile will start with single vision correction. We then reassess the patients after different time slots. We were looking for ametropic eye growth is achieved or not. If it is achieved, we will just keep monitoring the children, and if not, we will intensify the treatments. On the high-risk children, we will intensify the dosage of atropine. In the significant risk child, we will give 0.01 atropine, and in the moderate risk, we will probably switch to the optical myopia management options that we have in practice. So this was it for me. Thank you for your attention, and we're happy to answer questions.
Good evening. I would also like to welcome you to this online event organized by the European Miopia Network. Some things about my work. I'm an optometrist. I graduated from the University of Manchester 3 decades ago. For the last 24 years, I'm based at the University of Crete doing research in vision science. I'm also very fortunate because for all these years I have been practicing as a clinical optometrist at our practice in Heraklion and Athens. Regarding now the field of myopia, I've been recently become a council member of the European Myopia Network. I've been an ambassador for the International Myopia Institute for 5 years now, and also a past member of Myopia Management Advisory Board for Child's Vision. So the first question in this presentation has to do about the ocular parameters that influence refraction, and we do know that the most important ones are the curvatures and the powers of the refractive cells of the eye. This is the front and the back surface of the cornea and the crystalline lens. Also of importance are their positions in the eye and their thicknesses. We do measure the anterior chamber depth, the axial length, and collar and lenticular thickness that also play a role in the final power. Finally, we do know that refraction also depends on the refractive indices of this media. So we are aware of the lens gradient index, which also changes with age and in cases of cataract. Now, these graphs are from one of the first datasets available from a study in Sweden by Stenström 80 years ago. This is a landmark study actually, and each graph shows the population distribution of each of the ocular components of the eye. So we have corneal radius, anterior chamber depth, lens power, axial length, and then the final result, which is ocular refraction. What we can see is that although there is a very wide range of ocular parameters for each ocular parameter, you can see here that the corneal radius ranges from 7.2 to 8.8 millimeter, similar wide ranges for the anterior chamber depth and the axial length and the lens power. Then the resulting power doesn't show such a big variance, and it's very close to emetropia. Actually, it's about 1 diopter of hypermetropia. We do know that under normal conditions, children born hypermetropic of about +2 to +2.5 diopters on average. This schematic video from Rosema et al. Publication 2022 is very nice, showing how the axial length of the eye grows as the child becomes older. So we do know that, as is the case with height and weight, also the eye increases in length, height, width, and volume. But we have to bear in mind that the adult eye is not simply a larger version of the newborn eye. And emetropization exists, so we do know that the growth is coordinated between components, the cornea, the crystalline lens, and the axial length, in order to achieve emetropia. Now this graph here may seem very complicated. It plots the axial length on the y-axis as a function of age, and has superimposed plenty of data sets. So we have data sets shared from CHICE, is a data set from Asia. They are the green symbols here. The filled ones are boys, and the open ones are girls. Also, we have from Germany, Caucasian population, which are the pink ones. Again, the filled squares are the boys, and the open circles are the girls. And also some data from Greece, which is only on boys, are these black dots here. And all over them is superimposed some data published by Yi 2-3 years ago, which is average data from population. These are the blue lines. It's very evident that the axial length in emetropic eyes, because all these eyes are emetropic eyes, increases with age. And this reaches a plateau at about the age of 14 to 16 years. Another observation is that the emetropic boys have longer eyes than the girls, both in the Caucasian and the Asian population, by about 0.5 of millimeters. And also, the metropic eyes in Asians are longer than Caucasians. This observation is evident for both boys and girls, and the axial length difference about half a millimeter. Now, this data here, as data from a Gullström project, which shows the average axial length for different age groups now, older adult subjects, so it's about 20 to 30, 30 to 40, 40 to 50, and older age groups. And you can see it's like a continuation from the previous curve. So emetropic eyes seem stable over the years, although we have such a wide range of axial length, in the population. And we do know that this increase in axial length in the first years of the life for boys and girls is not different, and also is not different between Asians and Caucasian in the emetropic population. So this graph then has plots the annual axial length growth as a function of age, and you see that this growth decreases with age, as I said, reaching a plateau, at about 14 years of age. Now this graph plots same data sets, now the corneal radius as a function of age, and you can see for both Asian and Caucasian population, the average corneal radius is age independent, at least for ages over 3 years old. Now the girls show steeper corneas than boys in both Asian and Caucasian populations, whereas the Asian eyes have flatter, weaker corneas than Caucasians by about 0.05 millimeter, and this difference is similar in boys and girls. The same average corneal radius is observed for other age groups, and you can see that it's not very different to the average corneal radius as measured by Sorsby in 1957. Again, very evident is the wide range of corneal radius between the population. Now, how is refractive balance achieved for these children? So now we replot the data of these three populations we had from Chinese children, German children, and children in Germany and children in Greece, with a corneal radius on the y-axis and as an axial length on the x-axis. And it's very evident that there is a balancing achieved here between the axial length and the corneal power of the eyes. So flatter eyes, you can see here, correspond to longer eyes, and steeper curvatures correspond to shorter eyes. Although there is a huge variability in axial length between the population and also in the corneal radius, you can see that the slope, this balancing is similar to the three data sets. So the axial length range of hemetropic eyes is about 21 to 26 millimeter, and this is not only evident in children. Here now we have the data sets for older groups. You can see these are different decades, 20 to 30, going to 60 to 75 years of age. This is unpublished data from the Gulster project, and also compared to the Sorsby data back in 1957, and also some more recent data published in a manuscript by Age and Age in 2024. It's from Wisconsin. You can see again that the slope is not different between these data sets, showing the refractive balance between the corneal power and axial length that is the same across all age groups and does not differ a lot with what was found 75 years ago by Sorsby. Now we have shown that this refractive balance exists for all ages in emmetropes, but what is the case in other ametropia, so in myopia and hypermetropia? So this is again some data from the Gulstrom project, which plot the corneal radius as a function of axial length, and now we have different refractive groups. So the orange ones are the emmetropes I've been showing in the previous graphs. The red one are hypermetropes. The green points and the green line are low to intermediate, let's say, myopes, and blue ones are myopes with myopia over 5 diopters. And you can see that this slope, similar slope exists for all the refractive groups, with the difference that hypermetropic eyes later in life, they have a lower axial length growth compared to emmetropes, whereas the myopic eyes have a higher axial length growth compared to emmetropes. So to summarize, children are born hypermetropic, and growth of ocular components coordinated towards emmetropia early in life. There is a wide individual variation in axial length and corneal power among emmetropic eyes. However, the average emmetropic eye remains stable across the lifespan. It has not changed over the years. This is that refractive balance between the corneal power and axial length occurs very early in life and is independent of subsequent development in refraction. I would like to thank you showing an outdoor scene in South Crete. Thank you very much.
Good afternoon, everyone. I am Dr. Matteo Baldi from the University of Genoa, and today
I will be discussing choroidal thickness in relation to myopia. In recent years, the International Myopia Institute has highlighted the choroid as a key structure in myopia research. Once considered only a vascular support layer, the choroid is now recognized as a dynamic tissue involved in ocular growth regulation. Experimental studies have shown that changes in choroidal thickness in response to retinal defocus are closely linked to axial elongation, and as a result, the choroid is now considered both a potential biomarker and a therapeutic target in myopia control. Myopia development is closely linked to scleral remodeling and axial elongation, and recent evidence suggests that the choroid plays a direct role in these processes. Experimental studies have shown that myopic defocus induces choroidal thickening and slows axial growth, while hyperopic defocus leads to choroidal thinning and accelerated elongation. Notably, choroidal vascular and structural changes often precede scleral remodeling. The choroid may also regulate scleral extracellular matrix metabolism through growth factors and matrix metalloproteinases. In addition, treatments known to slow myopia progression, such as atropine and dopaminergic pathways, are associated with choroidal thickening, while reduced choroidal perfusion has been linked to scleral hypoxia and axial elongation. Overall, these findings support the concept of the choroid as an active regulator of ocular growth rather than a passive vascular tissue. Currently, two main quantitative parameters are used to assess the choroid: choroidal thickness and the choroidal vascularity index. Choroidal thickness is measured using enhanced depth imaging OCT as the distance between Bruch's membrane and the sclerochoroidal interface. Although widely used, choroidal thickness alone does not distinguish between vascular and stromal components and may show variability across studies. For this reason, choroidal vascularity index was introduced as a more detailed biomarker, and it represents the ratio between the luminal choroidal area and the total choroidal area, providing additional information about choroidal vascular status. Over the last decade, OCT imaging has shown that myopic eyes generally exhibit reduced choroidal thickness, particularly in association with increased axial length. Longitudinal studies suggest that choroidal thinning may precede or accompany myopia progression, supporting its role as a potential early biomarker. At the same time, myopic eyes often demonstrate reduced choroidal perfusion and vascular remodeling. These observations reinforce the idea that the choroid acts both as a biomechanical modulator and as a vascular metabolic regulator involved in ocular growth. Importantly, several myopia control strategies such as atropine, orthokeratology, less lattice spectacles, and repeated low-level red light therapy have been associated with measurable changes in choroidal thickness and perfusion. This figure illustrates how multiple wide-field OCT scans can be combined to generate a panoramic map of choroidal thickness extending into the retinal periphery. Using automated image registration, overlapping OCT volumes are aligned and merged to reconstruct both the wide-field retinal image and its corresponding choroidal thickness map. This technique allows a more comprehensive evaluation of peripheral choroidal structure, demonstrating that choroidal thickness progressively decreases towards the retina periphery. This figure shows the topographical distribution of choroidal thickness in myopic and non-myopic children within the central macular region. Compared with non-myopic eyes, myopic eyes exhibit a thinner choroid, particularly around the foveal area. The color-coded difference map further highlights that the most significant thinning is concentrated centrally, supporting a close relationship between central choroidal structure and refractive status. This second figure illustrates the wide field distribution of choroidal thickness in myopic and non-myopic young adults across a 14 mm retinal area. Compared with non-myopic eyes show a generalized reduction in choroidal thickness, with the greatest thinning located in the central macular region. The difference map also demonstrates that myopia-related choroidal thinning is not uniformly distributed, but predominantly affects the central retina. These OCT images compare highly myopic eyes with an age-matched emmetropic eye. The scans clearly show the marked choroidal thinning typically associated with high myopia, particularly in the subfoveal region. In contrast, the emmetropic eye exhibits a thicker and more preserved choroidal profile, highlighting the strong relationship between choroidal thinning and myopic ocular elongation. Recent systematic reviews and meta-analyses have shown that most current myopia control strategies are associated with early increases in choroidal thickness, further supporting the idea that the choroid dynamically responds to therapeutic interventions. Among the available treatments, repeated low-level red light therapy appears to induce the greatest choroidal thickening, while orthokeratology and defocus-based optical treatments also demonstrate rapid and sustained effects. Experimental evidence suggests that the choroid responds quickly to retinal defocus and visual stimuli, behaving as a highly adaptive tissue involved in ocular growth regulation. Pharmacologic interventions such as atropine also appear to modulate the choroid, although in a dose-dependent and more heterogeneous manner. Overall, these findings suggest that choroidal modulation may represent a common biological pathway shared by different myopia control strategies. Recent randomized controlled trials and meta-analyses further suggest that major myopia control interventions, including, as we have already said, low-dose atropine, orthokeratology, lensless spectacles, and repeated low-level red light therapy, consistently induce early choroidal thickening in children. Current OCT-based studies indicate that this thickening reflects changes in both the vascular and stromal compartments, likely related to alterations in choroidal perfusion and tissue fluid dynamics. Several studies have also reported an association between greater short-term choroidal thickening and reduced axial elongation, supporting the hypothesis that the choroid may act as a dynamic regulator of ocular growth. However, important limitations remain. The International Myopia Institute emphasizes that short-term choroidal changes should not yet be considered definitive biomarkers of long-term treatment efficacy, as measurements are influenced by factors such as diurnal variation, accommodation, cycloplagia, protocols, and, of course, OCT technology. Overall, current evidence reinforces the concept that the choroid represents a biologically relevant and clinically promising target in myopia control, but further standardized longitudinal studies are still needed. And, in fact, despite significant advances, several important questions remain unanswered. It is still unclear whether choroidal thinning is a primary driver of axial elongation or simply a secondary consequence of myopic growth. Similarly, the predictive value of early choroidal changes for long-term treatment outcomes remains uncertain. Future research will need to better define the biomechanical, vascular, and metabolic role of the choroid and determine which parameters are the most clinically meaningful biomarkers. Standardized OCT protocols and large longitudinal studies will also be essential. Ultimately, integrating choroidal biomarkers with axial length monitoring may help develop more personalized and precise strategies for myopia management. I thank you all for your attention.
Welcome to this presentation that reviews the clinical evidence on Essilor-Stellest lenses and what it means for myopia management in daily practice. My name is Gabi Steenbeckers. Global Medical Advisor Myopia in the Medical Professional Affairs team of EssilorLuxottica. As we know that myopia is becoming a growing global public health concern, in this presentation I will review the clinical outcomes related to Essilor Stellest lenses, summarized as 7 key facts. The focus is on what the clinical data shows and how these results may be relevant in daily myopia management. Outlined here, the presentation is for eye care professionals only and is intended for educational and training purposes. And it should not be copied or shared with others without Essilor's prior written consent. The information in the document is not for marketing or promotional claims or purposes. It's for educational and information nature only. With this context in mind, I will now move to the clinical evidence behind the Essilor Stellest lens. This slide summarizes the Essilor Stellest lens milestones. The evidence started in 2018 with a 2-year randomized double-masked clinical trial in China. This was followed by a long-term follow-up data extending up to 7 years, recently presented at ARVO 2026. In 2021, the US FDA granted the breakthrough device designation to Essilor Stellest spectacle lenses. Building on this, in 2025, the lens received US FDA market authorization. This decision was based on the 2-year data from a prospective, randomized, double-masked, multi-center clinical trial conducted in the US. Today, more than 80 publications supported the clinical understanding of Essilor Stellest lenses. With this evidence framework in mind, I will now focus on the main efficacy outcomes reported in the US and the Chinese studies. At the moment, Essilor Stellest are the first and only US FDA market authorized spectacle lens to slow myopia progression in children. This slide shows the key efficacy results after 2 years of wear. Across the clinical trials conducted in the US and China, myopia progression and axial elongation were reduced compared to single vision lenses. From the US results, the myopia progression slowed by 71% and a reduction of axial elongation of 53%. And from the Chinese trial, myopia progression was reduced by 67% and axial elongation by 60% on average compared to single vision lenses. Importantly, long-term data from China demonstrated sustained retention rate of 75% over 5 years. From a clinical perspective, these results highlight the relevance of Essilor Stellest lenses as an optical intervention for slowing progression across a range of ages and population. Beyond slowing the myopia progression, an important question in myopia management is whether intervention can begin even earlier. This slide addresses the potential role of Essilor Stellest plano pair lenses in children with presbyopia. The data shown from the study in children aged to 6 to 9 years using Essilor Stellest plano pair lenses with the goal of the study was to delay the onset of myopia. The results of this study with Essilor Stellest plano pair lenses demonstrated to slow down axial elongation in pre-myopic children when worn for more than 30 hours per week. There appeared to be a dose-dependent effect, with longer wearing hours corresponding to greater slowing of axial elongation. From a practical standpoint, this introduced the possibility of early optical intervention in selected children identified as being at risk. But what about the visual performance and the tolerance of Essilor Stellest lenses? Here you can see a summary of the visual performance outcomes in children wearing Essilor Stellest of various studies. As you can see, children adapted quickly, typically within 1 week. Distance and near vision acuity, accommodation, and binocular vision were compared to single vision lenses. And importantly, no significant impact on astigmatism was observed. There was also no evidence of rebound after stopping wearing Essilor Stellest lenses. And 90% of full-time wearers showed non-myopic eye growth rates after 1 and 2 years of wear. As we know, in some patients, monotherapy may be not enough, so combination approaches can be considered. As these slides present data on combining Essilor Stellest with low-dose atropine, results are shown from both European and Asian study, allowing assessment across different clinical settings. Across these studies, combination therapy showed greater efficacy than monotherapy. This additive effect was observed when Essilor Stellest lenses were added to the atropine monotherapy, as well as when atropine was added while Essilor Stellest lenses were being worn. So it can be considered in cases with ongoing myopia progression to use the combination therapy between atropine and Essilor Stellest or vice versa. Beyond these outcomes, it's important to understand the visual function and possible underlying mechanisms. As you can see on this slide, it focused on visual functions and potential mechanisms supporting myopia control. Visual performance through the treatment zone is reported to be better compared with other lensless design. Peripheral vision, reading speed, and a visual field measures were not effective when wearing Essilor Stellest lenses. This slide also showed potential mechanisms that may support myopia control. This includes reduced choroidal thinning and slower eye elongation, both centrally and peripherally. As we know in daily practice, not all children fit standard study population. The next slide will present data in specific clinical scenarios. You can consider Essilor Stellest lenses for special cases in myopia with awareness of evidence-based. In the case of NSI-mytropia, a study has shown that unilateral myopia slowed with corresponding slowing in a non-myopic eye when using Essilor Stellest for both eyes. For intermittent exotropia, myopia slowed without impact on fusion and binocularity. And in myopia of prematurity, the progress slowed in children born prematurely. Although data are more limited, this all can provide useful guidance for special cases of myopia. And I will now address the ongoing development of Essilor Stellest lenses design with the introduction of Essilor Stellest 2.0 lenses. Essilor Stellest 2.0 lenses are powered by Halt Max with increased lenslet power and aspheriority. Based on a 12-month data of a contralateral crossover clinical trial, axial elongation was further reduced by almost half compared to Essilor Stellest lenses. The results of the clinical trial also indicated that younger children, age of 8.5 years and younger, may potentially or particularly benefit in terms of slowing axial elongation. Regarding compliance, 84% of children were wearing their spectacles at least 12 hours per day, 7 days per week, with a mean wearing time of about 13.5 hours per day. This was all achieved without negative effect on visual performance, plus there were no dropouts during this trial. Here you can see the summary of all 7 key facts of Essilor Stellest lenses. They cover efficacy, visual performance, early intervention, combination therapy, special cases, and innovation. Together, they reflect the current clinical evidence supporting informed myopia management. The reference supporting the presented data are listed here. They include randomized controlled studies and trials, long-term studies, and underlying mechanism research. Thank you for your attention and enjoy the rest of the event.
Pilar Merino, I suppose that she will join in a minute, but let's start. Professor Yelena, if you may.
Yeah. Hello, everyone. I would like to thank everyone for great presentations, and I have comment and one question for Dr. De Mayri. I think this is exactly where the field needs to go. Your axial length change method is a practical tool that actually measures the trajectory of the individual child, not just the diopter. And you're finding that only, I think it was about 1 in 3 eyes succeeded with a faster pre-intervention rate, predicting the biggest reduction. Makes the same point I keep coming back to. The real question isn't which lens, I think it's which child. And my own question, could the faster progressors simply have more room to slow down so they look like the responders, while a naturally slow child can never reach success? How do you separate the true treatment effect from regression?
Yeah, thank you for the question, and I completely agree with your point there. It could be because they're progressing faster that they have a bigger difference to go, and therefore they're showing a larger level of slowing because of that. We did have quite small subject numbers, but the finding that the pre-intervention axial length rate was the best or the only predictor for a more successful intervention was fairly consistent amongst a lot of those children. So yeah, I agree with your point.
Thank you.
Thank you. Can you hear me? Thank you very much for your interventions. Have anybody wants to do any questions for the rest of the speakers about these subjects?
Just a comment to Yelena that the choroid thickness can be a predictor. If you measure the choroid before start an intervention and after, and it's independent that you measure it an hour later or 2 months later than you started the intervention. If there is a thickening in the choroid, your treatment will be effective. And if there is no thickening in the choroid, maybe less effective. And the first year treatment response is a good predictor for the long-term effectivity. Thank you.
Okay. I would like to ask to all of the speakers if you use, for example, orthokeratology to treat the myopia. Have you had any complications with this type of lenses in children, for example? What is your experience in general?
I can comment on that.
Yes, please.
We didn't have any complications at first. The first couple of years we did AutoK. We used a solution based on povidone iodine, and during that period we did see some corneal staining, and then we switched to the same one as Beata talked about, the peroxide based solution, and after that we haven't had any corneal staining the same way as we saw before. So I think it's really a matter of the way you handle the lenses and also the solutions that you choose, and the experience level from the clinicians.
And at what age do you consider you have to stop the treatment with orthokeratology in children?
At what age?
Yes, at what age?
We don't differentiate between the different ages when we choose when to stop between the different modalities. So we never stop the treatment until the child is at least 15 years. And when the child is at least 15 years and there's no more actual progression or the progression of the actual length, then we will stop the treatment. But it's not related to AutoK. And actually we don't really use AutoK as the first choice anymore. Previously that was the only thing we had before we had the spectacles. But I would definitely choose the spectacles now, unless the child chooses later on, usually during the teenage years, to get a contact lens-based solution.
For the rest of the treatment for atropine, okay. Do you want to make questions?
Yes, I was going to say we have small numbers relatively of patients in OrthoK, and we have a similar experience of very little ocular complications. But I was going to actually ask Train on the point of solutions. What we are seeing are lots of deposits on the OrthoK lens, which aren't easily, under the slit lamp, if you look at them under the slit lamp, which aren't easily removable with manual cleaning at the time of the consultation, or seemingly with protein removal tablets. Do you have that experience, and what type would you advise the peroxide solution as a better solution for that, or do you have any other suggestions?
Used a deep cleaner. I don't exactly remember the product right now because we haven't used it for some time, but because we don't do AutoK in our clinic anymore, we outsourced it to opticians. But we did use a deep cleanser every 3 months, and when we used that, it wasn't there was no more issues on that. Actually, we didn't use it the first 6 months of wear. Then the child just used the regular cleaning solutions, but after 6 months, then we deep cleaned them, and then we did that at visit 9 months and 12 months before we had the lenses replaced right after the 12 months visit.
Okay, thank you.
Thank you very much. Do you have any questions to the rest of the speakers, or something, or somebody wants to speak? Any question? I would like to know which is your preferred for any of the speakers. When the child is 5 years old, and she or he has, for example, one diopter of myopia, 1 to 2 diopters of myopia, do you prefer to do the treatment with an association, for example, glasses with atropine, only atropine, or ortho-key? What is your preferred treatment, please? Anyone?
If I can answer, I think that the less invasive methods is eyeglasses. So I'm sure that it's better to choose the non-invasive methods to start in an eyeglasses, and just it depends on the axial length. So we have to check the axial length, and it's much better not just examine the axial length. It's not a new method, but we take into account the axial length to corner radius ratio, because the refraction is depend not just the axial length, the corner radius influence the refraction as well. So if the axial length to corner radius ratio is around 3, it's similar. It means that the child eye is ametropic. However, if this ratio is over 3, the child has a risk to become myopic later in life. So I just take into account that not just measure the axial length, take into account the corner radius as well, because if you have a flat cornea, the child will begin at maybe 26 diopter, and maybe he is just ametropic. So take into account this ratio, not just the axial length.
Another question would be, have you ever had any problem, or have you ever seen an strabismus secondary to the use of atropine in small children, in younger children, accommodative or any other type of strabismus? Or do you use atropine if the child has strabismus? Do you have any experience about that? Does anybody? It's because there are some articles, recent articles in the literature that have published problems with the use of atropine. One case of accommodative or refractive isotropia in a child that was treated with atropine drops. I have not any problems with atropine, and I have been using atropine for many years. But in cases with strabismus, I prefer not to use atropine. Do you have any questions or any?
In the UK, we have only just recently received licensing for atropine, so I'm excited to get started and to hear what others have to say, but I don't have any experience of it yet.
Okay. In Spain, we don't have the commercial atropine, but we have been using for many years, and I think we don't have any problems with the atropine until the moment. But I prefer not to use in cases with strabismus. I prefer to use glasses, for example. Okay. So if you don't have any questions, we can finish this session because we are on time. And I think there is not any questions in the public, so okay. Very
Dear colleagues, thank you for joining this presentation. In myopia control, we commonly report percentage efficacy, mean axial length reduction, refractive change, and statistical significance. These metrics are important, but they do not fully answer the clinical question. This is what I want to solve with reporting myopia control efficacy as physiological axial growth and number needed to treat. This review table is a typical starting point in myopia control evidence. It summarizes atropine trials, concentrations, sample sizes, age ranges, and treatment effects. Scientifically, this is useful, but clinically, something is missing. Why classical reporting is incomplete? This slide shows why classical efficacy reporting can be misleading if it's used alone. Historical controls are not equivalent to randomized concurrent controls. Broad age ranges hide biology. A 4-year-old and a 16-year-old have very different growth expectations. Sex stratification is often missing. And the same absolute reduction can mean different things. Reducing growth from 0.3 to 0.2 millimeters is not the same as reducing it from 0.8 to 0.7 millimeters. The number is identical, but the biological meaning is different. That is why we need a physiological reference, not only less axial growth, but age-appropriate axial growth. To explain the logic, I use an arrest style example. In AMD, a relative risk reduction is about 30%. This sounds impressive, but clinically we ask, what does that mean in absolute terms? If 28 of 100 patients progress in the placebo group and 20 of 100 progress with treatment, the absolute risk reduction is 8%. The number needed to treat is about 13. That means treat 100 patients, prevent 8 additional progressions. That number is tangible. It tells us how many patients must be treated for 1 additional patient to benefit. The same logic can be applied to myopia control, but only after we define a meaningful endpoint. Here, the endpoint is reaching physiological axial growth, the MMC green zone, over a defined time horizon. So, what MMC means? Well, MMC means age-matched myopia control. The concept is simple. Axial growth should not be judged by one universal threshold. A 6-year-old has a different physiological growth expectation than a 12 or 14-year-old. The same growth rate may therefore be acceptable in one child and excessive in another. MMC asks, is the observed growth appropriate for the child's age? This shifts efficacy reporting from relative inhibition toward biological normalization. The goal is not merely to reduce growth. The goal is to bring growth back into a physiological corridor. The MMC zones translate axial growth into clinical action. Green means physiological growth, the treatment target is reached. Importantly, green does not automatically mean that treatment should be stopped. It means that current management is sufficient and the child should continue to be monitored. Yellow means moderately excessive growth. This is the warning zone and should trigger closer monitoring or treatment optimization. Red means highly excessive growth. Treatment is strongly indicated, or the current treatment may be insufficient. So the objective is simple. Move children or eyes from red or yellow into green. That movement is what will later translate into number needed to treat. Now we move to the new study you just heard this morning. This slide shows the baseline characteristics of single vision MyoSmart and MyoSmart IQ, representing the DIMSTAT concept in this presentation. The key point is comparability. Sample sizes are similar. Mean age is in around 8 years in all group and baseline refraction and axial lengths are close. Therefore, later differences are less likely to be explained by one group starting younger, more myopic or with longer eyes. The clinical question is not only whether optical design reduces mean growth, the clinical question is whether it changes the growth trajectory enough to reach physiological axial growth. Here we compare single vision with first-generation DIMS using MMC. With single vision, 73% of eyes are in the red zone and only 22% reach green. With DIMS, the red zone falls to 31%, while the green zone rises to 57%. That is not just a lower mean value, it is a shift from pathological growth toward physiological growth. The absolute increase in green zone responses is 35 percentage points. For this endpoint and this time horizon, the number needed to treat is 3. So DIMS is clinically effective, but a relevant red zone group remains. This is where MMC becomes useful. It shows residual biological need, not only mean efficacy. The comparison between DIMSTAT is stronger. The red zone proportion decreases from 73% with single vision to only 9% with DIMSTAT. At the same time, the green zone proportion increases from 22% to 82%. This is the MMC message. The enhanced design does not merely reduce average growth, it moves most eyes into physiological corridor. The absolute green zone increases in 60% points. For MMC-defined physiological growth over 1 year, the number needed to treat is 2. This is a strong absolute clinical effect in this cohort. This slide places single vision DIMS and DIMSTAT onto the MMC map. The pattern is intuitive. Single vision remains in the excessive growth range. DIMS moves growth downward toward the physiological corridor. DIMSTAT grows further into a close to the green zone. This is the visual equivalent to the number needed to treat result. We are no longer speaking about absolute percentage inhibition. We are asking whether the population reaches the biological target. Less growth is efficacy, physiological growth is sufficiency. Now we look at age groups, starting with single vision. The youngest children show the highest axial growth rates and are most clearly above the physiological threshold. This is expected. Younger children have stronger growth drive and more years of progression ahead. But it also shows why age matching is essential. The same axial length increases has different meaning at age 6 than at age 12. If we only report pooled means, the subgroup with the highest biological need may be diluted. MMC makes the subgroup visible. After adding DIMS, the age group pattern shifts downward. Across age groups, axial growth is reduced. Older and intermediate age groups may approach or enter the physiological range. This confirms that first-generation DIMS can be sufficient in many children. However, the youngest age strata will still show residual excessive growth. This is the difference between efficacy and sufficiency. DIMS may reduce growth, but in some young children the remaining growth is still above the physiological corridor. This is a signal for risk-stratified escalation. With DIMSTAT, the age group pattern shifts further downward. More age strata reach the physiological corridor and the effect appears particularly relevant in younger children. This matters because younger children are the most demanding group. They have the strongest growth drive and the longest future risk exposure. So the question is not only whether DIMSTAT performs better on average, the key question is whether it performs better. If the added benefit appears where first-generation DIMS may be insufficient, DIMSTAT becomes a meaningful escalation concept. The age-stratified number needed to treat values support this interpretation. For single vision versus DIMS, the number needed to treat is about 3 in children aged 7 to 9 years and about 2 in children aged 10 to 12 years. For single vision versus DIMSTAT, the number needed to treat is about 3 in the youngest group and about 2 in the older groups. The most interesting comparison is DIMS versus DIMSTAT. In the youngest children, the number needed to treat is 2. This slide summarizes the evolution framework. First, does treatment achieve the physiological eye growth corridor? That is the MMC question. Second, how large is the absolute treatment effect on axial elongation on target achievement? Third, what is the cohort's age and risk profile? A low-risk older cohort is not comparable with very young children with long axial length. Fourth, what proportion of pathological growth was normalized? And fifth, how many children or eyes need to be treated for one additional case to reach green zone physiological growth? Together, these questions move reporting from mean efficacy toward patient-relevant sufficiency. The complete report should include absolute benefit, number needed to treat, confidence intervals, and age and risk stratified analysis. Thank you very much for your attention.
Good evening, everyone. Today I'm going to present on light-based interventions to slow myopia progression. Those are my conflict of interest. So as you know, there is a rapidly expanding field and the evidence quality varies a lot. So today I will review outdoor light, as we know the best evidence for delayed onset. I will speak about red light therapy with the strongest device evidence. And also we will cover violet, blue, and cyan light therapies with the results that we have so far. We will also discuss transmission to the tissues and also safety concerns and how we can translate the evidence that we have so far to our clinical practice. So outdoor light has been the mechanism that has more evidence for the onset of myopia. So we know that more outdoor time reduce incidence of myopia. When we are considering progression of myopia, the evidence seems to be supportive. However, it's less definitive than for the onset of myopia. Also, when we are looking into outdoor time, we have to consider that this is not simply more intensity, it's also a complex visual environment. Also, outdoor time provides the rationale for light-based therapies, but does not validate any device protocol. So when we are considering natural light, we have to think about intensity, but more recently, we have data also on other factors that are important, such as the spectrum, the spatial cues, and also the behavior. So we know that 2 hours per day outdoors, it's a clinical recommendation for supporting myopia prevention. We don't know exactly the thresholds for intensity yet, although some studies have suggested that above 2000 lux, it's a protective environment. And also questions regarding timing remain unresolved. And of course, we need further studies using wearables to have objective data from outdoor time. Repeated low-level therapy, red light therapy has been the device and that showed the most promising results. So as you can see, typical protocol is 650 nanometers, 3-minute session, twice daily, 5 to 7 days. It's a home device therapy. This is, I think, one of the longest studies we have seen so far with 3 years efficacy, a multi-center real-world study. So overall, from the evidence that we have seen so far from RCTs, but also meta-analysis, actual length is reported to be slowed with this treatment, but also refractive progression. There are some studies also showing actual length shortening and also a rebound phenomenon or effect has been noted in some children. Nevertheless, is the device that or the treatment that has more mature evidence. Some discussion regarding biomarkers is still evolving. There are studies showing choroidal thickness, but also changes on retinal, choroidal, and vascular changes that are being studied as biomarkers of treatment response. The results so far that we have access are improving. We have more data nowadays. Nevertheless, the evidence remains concentrated in specific device protocols and populations. I'm going to show you now one of the studies done in Europe, in Spain, where the authors have looked into combined therapy, red light therapy, and orthokeratology. As you can see here from the data, they compared two groups, a group with red light therapy and ortho-K, and a group with ortho-K alone. It is interesting to see that in this study, in the combined group, 80% of the children achieved AL shortening of 0.05 millimeters, where this did not happen in the children or in the group with ortho-K alone. This study adds information about adjunctive treatment, combined treatment, that can be important for clinical practice, especially when we have a suboptimal response in some children to ortho-K alone, but also is an important study that shows that red light therapy is also effective in Caucasian Spanish children. And during 1 year, there was no severe adverse report or severe adverse events report on those children. Nevertheless, limitations are important. It is a small sample size, non-cycloplegic SE was used, and we need, of course, longer follow-up. We also need to understand more about the possible pathways because no single confirmed mechanism regarding how the treatment works. Here in this figure, you can see some of the proposed mechanisms, some related with retinal signal, with activation of mitochondrial activity, dopamine pathways, and also nitric oxide signaling. Of course, there's also choroidal response involved, such as thickening of the choroidal response, proposed mechanisms of increased blood flow, and of course, all can be expected or are being studied as a biomarker of effect of this treatment. It is important to consider mechanism because we need to understand how those can be used, how wavelength can be used, also the target tissues that are being affected by the treatment, and of course, safety monitoring. Safety is, of course, the central issue in red light therapy. We know that after image is commonly reported, but in some children it has a longer duration and they may be super responders to treatment. There have been some case reports and device output analysis that raise retinal safety concerns, as you can see here from the image on your right. This is an example of a case that was treated for 1 month with red light therapy and developed what you can see in the red arrow, which is a dome shape eye reflection, as you can see between the retinal pigment epithelium layer and the ellipsoid zone of the fovea. And this resolved after cessation of treatment, after 1 month of cessation. So, of course, we need to follow up with these patients and have monitoring endpoints such as visual acuity. But sometimes visual acuity can still be normal in functional tests. So OCT, I think, is an essential tool to follow up these patients, and other measures have been proposed, such as multifocal ERG. Of course, there's no clinical or research protocol that has been validated or a perfect protocol for now, but it is important to follow up these patients and consider reduction of the dose or stopping treatment if any of those changes are observed. It's also important to discuss more about tempering strategies. Also essential to understand that the changes that we see on those images seem to be reversible. Nevertheless, it is important to monitoring and have more studies on long-term safety for this treatment. Other example of a treatment that has been tested in an RCT with children is the Miopia X, which uses blue light stimulation, a blind spot stimulation. This is a European study with 11 sites. It's a home-based device smartphone with a VR environment. Most of the adverse events were mild or transient, so it was a more of a proof of concept study. When we look into the results, of course, it's less effective than the red light therapy, and at 12 months, there was no difference between the groups using Miopia X and dim spectacles. Other treatments have been tested, such as this one on violet light transmitting eyeglasses. This was a 2-year double-blind pediatric RCT. They found around 21% suppression of AL in selected groups, especially children with less near work and no previous spectacle wear. So there was a small treatment effect. In another study, more recently, Cyan Lights, with short-term human data, young adults with LED light-emitting glasses. This was a very short exposure of 120 minutes, and the authors found a small reduction of AL and also a small increase of choroidal thickness. So for this type of treatment, we don't have yet evidence of long-term slowing of myopia progression. So take-home message, light-based myopia interventions are promising, but of course clinical confidence differs by intervention type. Future trials should integrate efficacy, retinal safety, tissue dosimetry, and also biomarkers of response. Thank you for your attention, and I will be available for questions.
Good afternoon. We are Cristina Álvarez Peregrina and Miguel Ángel Sánchez Tena from the Complutense University of Madrid. Today, we would like to share an update of the prevalence of myopia in Europe. We will look at how it is changing over time, how it varies across different regions, and what main factors are behind these changes. To begin with, myopia is no longer a small or local problem. It has become a global health issue. In the year 2000, around 1.4 billion people had myopia. Today, we expect this number to grow to almost 5 billion by the year 2050. That means that nearly half of the world population could be affected. It also has a strong economic impact, with global losses of more than $200 billion due to incorrected vision. But more importantly, myopia is not just about needed glasses. In its several forms, it can lead to serious eye problems such as retinal detachment, glaucoma, and damage to the macula. We know that this increase is mainly linked to lifestyle changes, especially less time outdoors, more near work, and more use of digital devices. In the past, myopia has been strongly associated with East Asia, where prevalence among schools can reach up to 90%. Europe, in contrast, was traditionally considered a relatively stable region with moderate prevalence. However, recent evidence suggests that this situation is changing. 3 meta-analyses published between 2025 and 2026, including nearly 500,000 individuals, show that Europe is now undergoing a clear epidemiological transition. Changing lifestyles, urbanization, and educational pressure are all contributing to an increase in myopia prevalence, bringing new challenges for clinicians and public health systems. If we look at the overall prevalence, Europe currently sits between approximately 23.5% and 24.9%. At first glance, this may appear relatively moderate compared to Asia, but the detailed data reveal a much more concerning scenario. For example, in some adolescent population, the prevalence can approach around 50%, indicating a significant rise in younger generation. Furthermore, around 3% of the population already present high myopia, defined as -6 diopters or more. This is particularly important because high myopia is strongly associated with irreversible visual complications, making it a major concern for future eye health. When we analyze the data by age, a very clear patterns emerge. Prevalence increased progressively across the lifespan. There is a particularly sharp increase during adolescence, especially between 11 and 15 years of age, where prevalence rises rapidly. In adults over 20, rates can exceed 30%. This suggests that adolescents represent a critical period for myopia development and progression. Environmental factors, especially sustained near work, educational demands, and reduced times outdoors, appears to play a key role in accelerating this process. It's also important to highlight that the heterogeneity across studies is very high, reflecting difference in study design, population, and measuring methods. When we place Europe in a global perspective, it occupies an intermediate position. Adolescent myopia prevalence in Europe typically ranges from 30% to 50%, which is significantly higher than in Africa, where rates are often below 20%, but still lower than in East Asia, where prevalence can reach to 60% to 80% or more. This difference emphasizes that myopia is strongly influenced by environmental and lifestyle factors, and they highlight the need for region-specific prevention and management strategies. Another key message is that the European average can be misleading. There is substantial variability between countries and regions. For example, in Finland, prevalence may be as low as 12%, representing one of the lowest rates in Europe. In contrast, in southern European countries, including Spain, adolescent prevalence often approaches around 40 or 50% in a school. In fact, projections suggest that in Spain, myopia prevalence could reach approximately 30% by 2030. This variability strongly supports the idea that the environmental exposure play a major role in shaping myopia epidemiology. Now, I will hand over to my colleague Cristina Álvarez, who will continue with different aspects.
Thank you, Miguel. Now, I would like to direct your attention to a major issue in European research, which is the cycloplegia debate. We know that in Europe, not all eye care professionals are permitted to use cycloplegia. When you combine this with the busy environment of school screening, you realize why so much of our data is non-cycloplegic. And the main risk here is that we might be overestimating how common myopia actually is. If you look at the data from the 3 meta-analyses, the difference is clear. Without cycloplegia, prevalence reaches around 30%, but without it, it drops to 20%. So a key question we must ask is, are this rising number a true increase or just a result of how we measure? Well, according to our ongoing research in Spain, the trend is real. We have been monitoring children annually since 2016 with the same methods. We started with a 16% prevalence in 2016, and by 2025, that number reached 21%. However, although the increase is real, it underscores a critical message. We must prioritize relaxed accommodation in our studies, or at the very least, implement mathematical correction models. Now, knowing from our experience in Spain that this increase is actually happening, we must ask, what is driving this trend? Well, there are 3 essential drivers, and the first one is the education effect. We often say that genetic provides the blueprint, but the environment builds the eye. While genes set the stage, it is the environmental pressure that triggers the development of myopia. In fact, the link between academic demands and myopia shows a clear dose-response relationship between years of schooling and refractive errors. Simply put, more years of education directly mean a higher risk of myopia. And why does this happen? Because higher education leads to three things combined. A massive increase in close-up work, a significant increase in screen time, and a major reduction in the hours that children and teenagers spend outdoors. The second and the third drivers are the outdoor deficit and the digital proxy. First, the rapid growth of urban environments across Europe has led to a significant drop in the time children spend outdoors. And why is this so critical? Because natural sunlight triggers the release of retinal dopamine. So without enough hours outside, this natural break simply doesn't work. Second, while the debate about the direct impact of screen time continues, most researchers agree on one thing. More time with a screen is actually a proxy. This means that high screen time simply translates into things: more hours doing close-up tasks and a major reduction in outdoor time. What are the two true drivers of myopia? So what are the clinical implications of all of this? Well, we need a change in our approach. European eye care professionals must move from simple vision correction to proactive myopia management. And to do this, we need to focus on three main areas. One, early detection. We must work on identifying myopia as soon as possible. Two, using the right tools. We need to use the options that already have strong scientific evidence, like atropine, spectacle, contact lenses, ortho-K. And three, acting now. We need a proactive strategy to prevent today's myopia children from developing severe eye problems in the future. Our goal is to protect their vision for the long term. To finish, I would like to summarize the key takeaways for our daily practice. First, age matters. We need to monitor our European patient very closely during the high-risk window, which is between age of 6 and 17. Second, methodology is the queen. And finally, public health messaging. We need to encourage what we call green time, which is simply outdoor activity. We should present this to parents not just as a lifestyle tip, but as a serious clinical recommendation to protect their children's vision. In conclusion, the bottom line is that Europe is at a crossroads. While we are not yet at the crisis level we see in Asia, the trend is very clear. The data from 2025 and 2026 is a real wake-up call for all of us. We must change our mindset. If we continue to treat myopia as just a simple refractive error, we are ignoring a major public health crisis. To move forward, we need two things. One, common protocols, and two, integrated management. Managing myopia must become the standard of care. Thank you very much for your time and for your attention.
Dear Chairman, dear colleagues, in this presentation I am summarizing the associations between near work and outdoor activities with the prevalence and progression of myopia. And here are my conflict of interests. The term myopia came from Aristotle's text from ancient Greek, and it actually means a subject who is writing small script and squinting his eyes. And it seems that Aristotle is squinting his eyes, and also one of the gentlemen there beside is also myopic. Experimental myopia can be induced in different animal species by interfering the distant vision in different ways for the first few days to few weeks or months, and the short interruptions in experiments reduce the induction of myopia. What is near work? The definition varies quite much in different studies. Some studies include computer use and watching TV as near work factors, especially in using diopter hour as a near work measure. This is clearly near work. according to my studies, watching TV is not a risk factor for myopia. On the contrary, it seems that it actually can prevent myopia, especially when the time used watching TV is increasing. There is no consistent view whether use of computer increases myopia or not. It depends perhaps of the intensity of its use or distance where it's used. There are several studies showing that mobile phones are risk factors for myopia, and especially in young children. But the association is depending much what kind of use is it. Is it listening music, playing games, or studying? The prevalence of myopia in Germany was very common 150 years ago, so that in many schools the prevalence was as high as it nowadays is in many Asian countries. Here are some pictures from the Helmut Kohn's textbook of myopia. Kohn paid attention on the factors associated with near work, and for example, reading posture, reading distance, how intensive and long the reading sessions are, and what are the breaks. When near work from the short distance was regarded as a significant factor inducing myopia, different devices were constructed, and here is one of them to prevent too short reading and writing distance. Here is still one picture showing how short distances schools used when writing the text. In one of my studies, the prevalence of myopia increased in proportion to the amount of near work. And it should be noted that, for example, the prevalence of myopia among 11-year-old fifth grade school children was only 3% if the amount of daily near work was not more than 1 hour. It's well known that time spent outdoors is preventing myopia, but it's not clear if the brightness have any additional effect on that. In my own study, the prevalence of myopia was the less, the more was time spent outdoors. When comparing the risk factors for prevalence of myopia in school children at different combined levels of near work and outdoors time, the outdoors time prevented myopia at different levels of near work time, but relatively less in the higher levels of near work. A recent study from Finland among Finnish conscripts showed that prevalence of myopia in Finland has not increased, and in this study it was 23.5%. We studied what kind of interactions there was between prevalence of myopia and near work time, outdoors time, using mobile phone and level of education. From this figure, we can see that near work increased the prevalence of myopia at each level of smartphone use and its level of education. However, the probability of myopia was highest at the lowest right part of figure, where those who were studying at university the prevalence was highest. And when comparing the first part of smartphone used 1 hour, there the prevalence of myopia among them was lowest. When making the same comparison for time spent outdoors, the figures are quite similar, but the prevalence of myopia is decreasing, and similar difference between highest education is seen among those using less amount of smartphone and highest amount of smartphone. And the same calculation about the smartphone use and the prevalence of myopia in different educational groups shows that in those who are studying in university, the smartphone use increases risk of myopia, and the slope of correlation is contrary in other educational groups, so that in those groups mobile phone use doesn't increase risk of myopia. There is great individual variation in progression of myopia, so that many factors has to be taken into account when calculating the future progression. As a summary, we can say that near work causes myopia, and the effect of near work on myopia is depending on the age of near work, distance, intensity, how long are the sessions of near work, how are the breaks, what is the posture, and so on. And when analyzing the effect of a progression, then in those factors tends to happen changes during the school years, so these changes ought to be taken into account. TV and indoors time do not increase myopia, and outdoors time prevents myopia at different levels of near work, and intensity of outdoors light doesn't matter much.
Hello everyone. I'm delighted to be with you today. First, I would like to warmly thank Professor Grzybowski for his invitation and for the opportunity to contribute to this myopia conference. When preparing this talk, I asked myself one question we still face in daily practice: who should be treated for myopia and when? Myopia management has shifted from corrected vision to preventing excessive eye growth. Today, the key question is no longer how to treat myopia, but who should receive treatment and when. This approach is not based on a single opinion. It reflects the consensus emerging from 31 International Myopia Institute white papers and the current evidence base. Before we decide who to treat, we must agree on definitions: myopia, high myopia, and pre-myopia, and all of three of these are measured under cycloplegia. The most important concept today is pre-myopia. Children who are not yet myopic, but whose refractive status and risk profile make future myopia likely, because it shifts the focus from treatment to prevention. The message is simple. We no longer wait for myopia to become severe before acting. Modern myopia management is proactive, risk-stratified, and focused on prevention as well as treatment. If there is one threshold clinicians should remember, it is minus 0.5 diopters under cycloplegia. Once true childhood myopia is confirmed, the question is usually not why treat, but why wait. age matters. A child who becomes myopic at 7 or 8 years of age carries a much greater lifetime risk than a teenager presenting with the same refractive error. Earlier onset means more progression, higher lifetime risk, and better treatment responsiveness. Now, let's move from established myopia to the child who is not yet myopic. This concept of hyperopic reserve has fundamentally changed how we think about prevention. A 6-year-old should still have a meaningful amount of physiological hyperopia. As children grow, that reserve gradually decreases. What matters clinically is that a child below the age-expected reserve may appear completely normal today, yet already be on a trajectory toward future myopia. This allows us to identify risk years before myopia actually develops. In many ways, hyperopic reserve is our earliest opportunity for intervention. This brings us to risk stratification. In practice, we rarely make decisions based on a single parameter. Instead, we combine multiple risk factors. Imagine an 8-year-old child with low hyperopic reserve, one myopic parent, limited outdoor exposure, and increasing axial length. The child may not yet be myopic, but the overall risk profile is already concerning. Conversely, a child with similar refraction but no additional risk factors may simply require observation. That is why modern myopia management is not about treating a number, it is about treating risk. This slide quantifies those factors. By how much does each shift the odds? Cycloplegic refraction alone is still the best single predictor. The biometric and familial factors refine it, they do not replace it. On the right is a striking UK signal. Children with longer eyes at age 6 were 2.5 times more likely to become myopic and over 6 times likely to develop high myopia by age 16. You can quantify risk before a child is ever myopic. Refraction can sometimes appear stable because the crystalline lens compensates for ocular growth. Axial length, however, directly reflects the structural change that ultimately drives myopia-related pathology. This is why, whenever possible, axial length should be measured alongside cycloplegic refraction. The numbers to remember: roughly 0.1 millimeters per year is consistent with normal growth, while 0.2 to 0.3 is more commonly associated with myopic progression. However, evidence provides no single axial length threshold that tells us to start treatment. Axial length is extremely valuable, but it must always be interpreted in clinical context. So how do we use axial length at the chair side without universal trigger? In an untreated school-age myope, sustained elongation of at least 0.2 millimeters a year or more than 0.1 over 6 months is clear active progression. Initiate treatment. Between 0.1 and 0.2 is a gray zone, weigh age, ancestry, reserve, and percentile trajectory. In an older child, even more than 0.1 a year is increasingly abnormal, because physiological growth has nearly stopped, and any eye approaching 26 millimeters demands retinal surveillance, whatever you decide about treatment. The key point is that axial growth is age-dependent. An increase of 0.15 millimeters per year may be perfectly acceptable in a young child, but would be more concerning in a teenager, whereas 0.3 is clearly excessive at almost any school age. Never interpret an axial length change without the age in front of you. A progression rate greater than 0.5 diopters per year is widely recognized as a marker of a fast-progressing phenotype and supports treatment, but treatment should not depend on waiting for progression to occur. outdoor time remains the most universal preventive strategy. More time outdoors reduces the risk of developing myopia and delays its onset. So for every child at risk, outdoor time may be the simplest prescription we can write at no cost. Every year of delayed onset is worth far more than a year of control later. Accommodation lag, near isophoria, and high ACA ratio may influence management choices, but they are not independent indications for myopia treatment. Infants and very young children with high myopia deserve a different approach. Here, the first question is not which treatment should I prescribe, but why is this eye so myopic? Before considering routine myopia control treatment, we must exclude underlying ocular or systemic causes. In this group, diagnosis comes before treatment. Myopia progression does not necessarily stop at age 18. Treatment decisions should be based on stability, not age alone. Not all areas in myopia management are supported by equally strong evidence. The strongest data support cycloplegic refraction, outdoor time, treatment of established childhood myopia, while pre-myopia treatment and some risk markers remain evolving areas. So we should act confidently where evidence is strong and cautiously where uncertainty remains. Let me finish with a simple clinical framework. Start with cycloplegic refraction and axial length whenever available. Established myopia goes directly to active control. Pre-myopia with risk factors enters a prevention pathway centered on outdoor time and closer follow-up. Age-normal hyperopia requires surveillance rather than treatment. And once treatment is started, monitor every 6 months, escalate if control is inadequate, and stop only when stability is documented, not simply because the child has reached a certain age. Before I conclude, it is worth recognizing both what we know and what we still do not know. The consensus is strong. Cycloplegic refraction guides decisions. Pre-myopia is a legitimate target for prevention, and confirmed childhood myopia deserves active management. Important questions remain, including axial lengths, cutoffs across populations, and the role of treatment before myopia onset. So while the details continue to evolve, the overall direction is remarkably clear. And that brings me to practical answer to our original question. If you remember nothing else but 4 words, treat, prevent, investigate, don't ignore. Treat established myopia, prevent in pre-myopes, investigate very young or highly myopic children, and don't ignore progressing young adults. Ultimately, candidacy begins before some children are even myopic and ends only when the eyes have truly stabilized. Thank you for your attention.
Good afternoon. This is a population study about myopia screening among first grade students in Tromsø, Norway. And being at 69 degrees north latitude, it dictates very special light conditions and light exposure of the children. So we wanted also to see the role of outdoor exposure in early childhood on the results. We wanted primarily to address previously non-documented myopia prevalence among the first grade students in Tromsø, and we did that by evaluating axial length and refraction distribution. We also wanted to explore the environmental context of this special geographic situation. The key questions were how myopia in first grade students fare compared to data from European studies, and to see if low light conditions at high latitude increase early myopia occurrence. It was a population-based school screening type study. The planned number of students was 200 eyes of 200 individuals in age between 6 and 7, so the average age was 6.3. We also measured the axial length, optical biometry, plus keratometry, and we measured non-cycloplegic refraction. Just to note that we chose non-cycloplegic refraction because of the limitations set by the ethics committee. And now the results. So far, 138 eyes of 138 students were examined and analyzed. It was 31.2% with myopia below minus 0.5 diopters and 14.5% with myopia below minus 1 diopter, non-cycloplegic measurements. And we know that those measurements may overestimate the real refraction, and we tend to believe that the true prevalence of myopia is likely closer to 14.5% rather than the double that non-cycloplegic measurements showed. Concerning the axial length, the mean axial length was 22.5 millimeters. And one special thing about that was that it was 23.7% with the axial length higher than 23 millimeter, which means that nearly 1 in 4 children were at structural risk of developing pathologic myopia. We also looked at axial length percentiles and compared to the distribution in European refractive curves currently published. The figure shows percentiles corrected for sex and age, and the dashed lines show the European data, while the color dots represent the data that we got in our study. We found out that actually 95 percentiles were the same as in the European studies. 50th, 75th, and 90th percentiles were slightly more representative for Tromsø, which means that lower percentiles were actually underrepresented in Tromsø. If we look at the summarized findings, first I would like to emphasize that our refractive findings are of moderate value due to non-cycloplegic nature of the exam, but our axial length findings are objective and should be considered as real. Concerning the refractive findings, there was a slightly increase in early myopia, but can be questioned because of the non-cycloplegic examination. Then we can see that the axial length shows normal growth compared to the European data. But our axial data analysis shows that 23.7% were at risk with axial length higher than 23, and this is a subgroup that is definitely showing a structural risk for developing high myopia. So the question arises, why high latitude, low light conditions not necessarily translates into more early myopia? If we look at the environmental challenge, the high latitude 69 degrees leads to no sun on the horizon from November 20th through January 20th. And our biological expectation would be that less ambient light would lead to expected increase in myopia risk. But on the other hand, we must recognize a protective modifier in our context, which is that all the preschool children in Norway are attending kindergarten, where the policy is to spend more than 2 hours per day outdoors daily. in some cases significantly more than 2 hours. We can conclude that the children were undergoing multi-year cumulative exposure to the outdoors before the school age, factor that counteracts the effect of low light exposure. So in conclusion, high levels of outdoors activity in early childhood may mitigate the expected impact of reduced daylight at high latitude. And we can also conclude that the environmental and lifestyle interact to shape the myopia risk. In addition, our data showing 23.7% of children having axial length above 23 mm may show the risk for development of high myopia before refractive data. And finally, about the scientific contribution, high latitude, no increased early myopia prevalence could be registered. Axial length distribution aligns with the European percentiles. And the final take-home message, high latitude does not necessarily translate into increased early myopia. Outdoor exposure in early childhood likely plays a significant role, and the axial length identifies children at risk before refractive change becomes apparent. Thank you for your attention.
Hi everyone, my name is Teele Paluma, and today I will present to you our real-world clinical data on 1-year efficacy and tolerability of 0.05% atropine for myopia control in Estonia. The study was conducted at the East Tallinn Central Hospital, where atropine eye drops were introduced into routine clinical practice a few years ago. Of course, as we know, low-dose atropine is one of the most effective treatments for slowing myopia progression, and among low concentrations, 0.05% has shown particularly good efficacy. But there are still practical questions about its use in European populations, especially in children with lighter irises, where side effects such as photophobia and near-work difficulties may be more prevalent. In Estonia, atropine drops were introduced in clinical practice in 2023 at the East Tallinn Central Hospital. These drops are compounded by the hospital pharmacy as preservative-free single-dose units. And here I'm reporting the treatment effect and tolerability for the first 33 treated patients. This was a prospective clinical cohort study. Children were eligible for treatment if their axial length was at or above the 75th percentile on the Dutch growth charts, and or if they had myopia progression of at least half a diopter per year. Patients underwent clinical examination at baseline and were followed up at 1 week, 1 month, and at 3, 6, 9, and 12 months after treatment initiation. For myopia outcomes, axial length was measured at every visit, and cycloplegic order refraction was performed at baseline and every 3 months. We also assessed tolerability using both objective and subjective measures. Objective measures included photopic pupil diameter and accommodation amplitude. Subjective measures were recorded at each visit. The final cohort included 33 participants. The median age was 12 years. Age ranged between 4.6 to 18 years. Sex distribution was balanced. And at baseline, the children had moderate to high myopia. The median spherical equivalent was minus 5.4. It ranged between minus 11.5 to minus 0.6. The median axial length was 25.4. We also assessed iris color of the patients using Seddon scale, which I'm depicting here on the right-hand side. And this was a predominantly light iris cohort, so over 80% had Seddon grade 1 or 2 iris color. First, looking at spherical equivalent refraction, the line plot shows the mean change over time, with individual participants shown in gray. And over 12 months, the mean change in cycloplegic spherical equivalent was very small. It was approximately minus 0.08 diopters. And interestingly, we saw a hyperopic shift early in the treatment. We also quantified the proportion of responders, which we defined as a spherical equivalent change of less than half a diopter per year, and it shows that 88% of participants had a very good response. We also performed subgroup analysis in participants who were aged less than 12 or more than 12 years, and we saw that spherical equivalent-wise, the effect was very similar across the two groups, slightly more responders in the young group. Next, looking at axial length. At 12 months, the axial length increased on average by only 0.052 millimeters. Interestingly, there was a small transient decrease in axial length during the first months of treatment, followed by this gradual increase toward 12 months. We did not measure choroidal thickness, but this decrease could be due to choroidal thickening. We again quantified the proportion of responders, defined as participants whose axial length changed by less than 0.2 millimeters per year, and overall 91% were good responders. And we saw that all of the over 12-year-olds had a full response to treatment. So taken together with the spherical equivalent results, this suggests a very favorable one-year treatment response in this real-world cohort. Now on to the side effects. At every visit, we asked the patients whether they had any of the complaints that you can see on the left-hand side and how much they were disturbed by them, with 0 meaning that they noticed it but it didn't affect their everyday life at all, and 10 being the most severe disturbance they could imagine. Side effects were very common early in treatment. At 1 week, large majority of participants reported they had noticed they had enlarged pupils, and almost half reported photophobia and difficulty with near work. When asked about how much they disturbed them, the median score for all these was moderate, between 4 to 5. But these side effects decreased rapidly over time, and by 6 months, very few individuals reported they noticed enlarged pupils, but no one reported photophobia nor near work difficulties. And the severity scores also decreased over follow-up, and they were a median of 0 at 6 months. Importantly, there were no systemic side effects, and overall the treatment was well tolerated. With regard to the objective tolerability, at 12 months, accommodation amplitude was reduced by approximately 2 diopters, and photopic pupil diameter was increased by around 1 millimeter compared with baseline. So physiologically, the expected atropine effects on accommodation and pupil size were present. But these changes did not usually translate into major clinical problems, as no participant required photochromic glasses or progressive glasses. 2 participants were temporarily switched to lower concentration atropine because of near work problems, but both later resumed 0.05% atropine, and no participant discontinued treatment. We were intrigued by the early axial length shortening we saw, and we were then wondering whether this early axial length change can also predict a 12-month treatment response. We did some linear regression analysis, and over there the outcome was a 12-month axial length change from baseline, and we tested 4 different time points separately. So we tested the predictor of axial length change from baseline to 1 week, baseline to 1 month, 3 and 6 months. And we adjusted the models for baseline axial length, age, and also sex. Because this was a prediction-oriented analysis, we summarized the model performance using adjusted R-squared. And this analysis should be considered as exploratory and hypothesis generating. And here are the results. On these graphs, you can see the axial length change from baseline to 12 months on the y-axis, and the early axial length change on the x-axis depicted separately for 3 months and for 6 months. And you can already see visually that the greater axial elongation at an earlier time point was associated with greater axial elongation at 12 months. We also quantified this, and we saw that this link was present already at 1 week, although evidence was weakest at that time point, and it became stronger as at later time points. At 6 months, the adjusted R-squared was 0.66, and the beta coefficient was close to 1, suggesting that the 6-month axial length change tracked closely with a 12-month outcome. So clinically, this suggests that early axial length monitoring may help identify children who are not responding optimally to treatment. So to summarize, 0.05% atropine was effective and also well tolerated for myopia treatment in this cohort with participants of primarily light irises. Side effects were common early on, but they were mild and also transient, and early axial length changes may predict 12-month axial length outcome, suggesting a potential role for early biometric monitoring during atropine treatment. There are several important limitations. First, the sample size was small. We also did not have an untreated control group, and we do not have data on pre-treatment myopia progression. Also, the follow-up is currently limited to only 12 months. And again, to reiterate, the prediction analysis was exploratory and not externally validated. Going forward, we plan to continue long-term follow-up to assess the sustained efficacy, potential rebound. We also aim to incorporate pre-treatment progression data whenever it's available. And we would like to validate this early axial length response prediction in an independent cohort. With that, I'd like to thank the East Tallinn Central Hospital staff for all the hard work they put into getting the treatment approved in the country and arranging the compounding and distribution of eye drops, and our research department for their advice on the analysis strategy. Thank you for your attention, and more than happy to take any questions you may have.
Welcome everyone, my name is Pablo Concepcion Grande, I am optometrist and I have been working as researcher in the design of ophthalmic lenses for 10 years. Since 2018, I've been working on the development and testing of MioExpert HD design. Today, I'm going to talk about how children use these lenses. First, I will discuss the importance of myopia management. Then I will move on to talk about the MioExpert HD lens design characteristics. And finally, I will talk about its efficacy results in a European population clinical trial. So, this table shows the risk of developing different ocular complications depending on the degree of myopia, where it can be seen that as the amount of myopia increases, the risk also increases, highlighting the importance of myopia management. Eye care professionals have proposed different treatment options to try to reduce the growth of myopia during the childhood and preventing consequences during the adult life. Some of the alternatives are related to modification of the lifestyle, pharmacological drugs, contact lenses, or spectacle lenses. Regarding spectacles, they are generally preferred by parents because of some advantages in comfort, aesthetics, and cost. These lenses are characterized by having a clear central zone and a blurry periphery, which is created by myopic defocus or diffusion. So, the degradation of peripheral image quality may contribute to slow down myopia progression in children. This figure shows the lens power map of MioExpert HD design, where red colors represent areas with higher positive power and blue colors represent areas with no power. The first thing that you can notice is a central oval area of 7 millimeters, which is a blur-free optical zone. This area provides central clear vision. In addition, there are 3 different peripheral defocus zones where the power achieves 1.50 diopters at 25 millimeters on the nasal side of the lens, 1.80 diopters at 25 millimeters on the temporal side of the lens, and 2 diopters on the inferior side of the lens. These zones create asymmetric myopic defocus, which helps slow down myopia progression while keeping the central vision clear. To test the efficacy of this lens, we conducted a randomized clinical trial, the first one in a European population, involving 3 universities in Spain and Portugal. We followed 83 children over 2 years, 42 of them started wearing standard lenses and 41 started the clinical trial wearing Mio Expert HD design. We measured their axial length at the baseline after 12 and 24 months. In this graph, you can see the evolution of axial length over time, where the black line shows the data of those wearing standard lenses and the yellow line shows the data of those wearing Mio Expert HD lenses. As you can see, Mio Expert HD lenses slow down myopia progression by 39% after 1 year and 29% after 2 years. Now we will move on to discuss how children use this lens. First, I will explain the eye tracking setup and then I will present the result of 2 different studies. The first one was made to compare the differences between wearing single vision lenses and Mio Expert lenses, and the second one it was carried out to compare the differences after 1 month of adaptation to Mio Expert lenses. So, the pupil position of a group of children were recorded using an eye tracking system during distance, intermediate, and near tasks, while children wear Mio Expert HD lenses and single vision lenses. The pupil position were projected onto the lens surface to identify the areas of the lens that were actually used for the different tasks. In this image, you can see an example of a heat map from one of the tasks. The figure shows the mean power contours of the Mio Expert design, which illustrate that in this case the subject mainly used the central area of the lens. So let's start with the first experiment. The objective was to compare how children use Mio Expert HD lenses versus standard single vision lenses by analyzing their gaze behavior. In this figure, you can see the lens usage area for different tasks for distance, intermediate, and near. The Mio Expert HD lenses is shown in yellow, and the standard single vision data is shown in black. So you can notice that with Mio Expert HD lenses, the lens usage area was smaller for all the distances, especially for intermediate tasks. So these results suggest that myopia management lenses influence how children look through different areas of the lens, which may contribute to their effort in controlling myopia progression. Regarding the second experiment we carried out, the objective was to analyze how children's gaze behavior and lens usage changed after 1 month of wearing Mio Expert HD lenses. So, regarding the results of this second experiment, on the left, you can see an example of heat map from the same subject during the distant task at the baseline visit on the left and after 1 month of using Mio Expert HD lenses on the right. First thing that you can notice is that after 1 month, the gaze pattern is more concentrated around the center of the lens. On the right, the figure shows the percentage of time that participants used different addition zones of the lens, where light colors represent areas of the lens with lower power and dark colors represent areas with higher power. This data is divided into distance, intermediate, and near tasks, both at the baseline and after 1 month of using Mio Expert HD lenses. So after 1 month, for all the tasks, the time spent is higher in regions of the lens with lower power. In other words, gaze behavior changed significantly after 1 month of using Mio Expert HD lenses. Children used small lens area less of the peripheral zones and look closer to the center of the lens. In this figure, you have the vertical pupil distribution for the three tasks analyzed, where the white boxes represent the baseline visit and the yellow boxes represent the visit after 1 month of using MioExpert HD lenses. So, for distance, intermediate, and near tasks, you can observe that for all tasks, after 1 month, children look through areas closer to the lens center of the lens. So, these results show that with time, children adapt their gaze to take advantage of the optimal optical area of the lens. Now, to wrap up the presentation, let's move on to the conclusions. First, MioExpert HD lenses are effective in slowing down myopia progression in European population. And second, children's gaze become more central and higher with MioExpert HD lens design, using central zones for comfort while keeping peripheral defocus for myopia control. Thank you very much for your attention.
Good evening, everyone. My name is Shifra. I am based at the Technological University of Dublin at Centre for Eye Research Ireland. So today I'm going to talk to you about how clinical communication in healthcare systems contribute to hesitation when it comes to myopia management. So what we're going to look at is why this matters, what parents currently think, why uptake fails, what influences decisions, and what clinicians can do about it. So this is a consultation many of us encounter weekly. Clinically, intervention seems straightforward, yet parental uptake decisions are often far more complex than the evidence alone. So why is evidence alone not enough to drive uptake? This is important. We know that nearly half the global population may be myopic by 2050, and more worryingly, 1 in 10 could be pathologically so. So this highlights the growing importance of effective parental engagement. Parents play a key role in decisions around prevention and myopia control interventions, and this includes time outdoors, lifestyle interventions, which form the backbone of everything we're going to do when it comes to myopia management. So what are parental perceptions? How do we understand and help them understand the impact of myopia in children's futures? So we know the prevalence is high and is getting higher. We know that early intervention is vital, but we know that we may advise, but parents will decide. So let's look at myopia control interventions very briefly, but just in summary, we have many different types, and we know, and the evidence will support, that we can expect about a 50% slowing of myopia progression once we use any of this range of interventions. And what dictates success is often adherence and wearing time. So it's important that we use a suite of technologies that are open to us at this stage. But parents do not enter the consultation with the same understanding of myopia. Those who have myopia themselves would view it very differently from parents who are encountering it for the first time. We're talking about health literacy, prior experiences, and personal anxieties, and these are all going to shape how recommendations are interpreted. So for many families, myopia is still seen as something easily corrected with glasses, not a lifelong eye health condition. And this temporal disconnect between the here and now and possible problems in the future reduces urgency around intervention and encourages a kind of a wait and see. So we can look at this the McCrath et al. Paper from 2018, and we see that only 46% of parents viewed myopia as a health risk, and a similar proportion saw it just as an inconvenience, and only 14% were really concerned. But then if we look at a more recent paper, we can see things have changed. And so we did see in this paper, well, not that we did, but the authors saw in this paper, and what the study found, was that peripheral defocus spectacles were the preferred treatment option, nearly half of those surveyed. But even though they are the least well known of the treatments, if you think about it, I mean, we've had orthokeratology, we've had multifocal soft contact lenses for a long period of time, like for decades for ortho-K, and at least 10 years of data on multifocal soft contact lenses. Yet, spectacles the authors suggest, felt safer, less invasive, and more familiar than contact lens approaches when it comes to children. And this is very relevant clinically because we want buy-in here, but we also need to ensure that we support the lifestyle that families and children have. We want to keep children outdoors and active, and sometimes maybe contact lenses can help with that. So we see from this paper too that parents are now understanding the retinal detachment is an issue and it's serious in association with myopia, but there's less understanding when it comes to cataracts and glaucomas. That's something we need to be aware of. Genetics, yes, it is key, and this is what parents believe plays a significant role. Screen time since COVID is more widely recognised as a cause, but, and this is important, there's a big but, outdoor time's impact on myopia is often overlooked. And this is key because we need to think about daily activity patterns, near work and outdoor time, and how we can support families to support children to slow down myopia progression. And that includes the lifestyle piece. There are other barriers. There are non-clinical barriers. So let's say even the most motivated parents may not be able to proceed if the interventions are financially out of risk. The financial consideration impact treatment adherence so significantly. Also, routines. Integrating new habits is challenging for all of us. Also, long-term commitments can lead, to adherence fatigue and dropout. Even in the clinical trials, this was seen, and these parents are really bought into it. And then sustained efforts are absolutely necessary because we're going to be engaging in myopia management through childhood, adolescence, and into early adulthood. Daily routines and complicated adherence to treatments, there's no doubt about it. But what was interesting in some of the studies here, and this is key, communication gaps. So ineffective dialogue creates misunderstanding and fear. So we need to point people in the direction of reliable sources of information, such as the WMCO, Myopia Management Navigator. Also, as time goes by, we have emotional barriers, and also peer influence is going to be important as moving through into adolescence. But I think it's key here though, and this came up, if parents perceive recommendations as sales-driven rather than health-driven, trust deteriorates quickly. And then there's the parental risk perception. So we're talking about the here and now versus what's going to happen in the future. Parents underestimate long-term risks, and aren't we all the same? So maybe we need to think about, do we frame myopia as an inconvenience versus disease? This is crucial, but we have to be careful here as well, because parents are more concerned about quality of life than future pathology. And aren't we all? We'd like to think about the here and now as opposed to possible problems in the future. So just when we're talking about myopia, if we keep talking about diseases, visual impairment in the future, we may be missing a key communication piece here. We need to talk about the quality of life. I think a wonderful line now from the Carney et al. Paper was, you think of what kind of life your child is going to have and what they are going to be able to do and see. I think this is important. We need to get back to the quality of life. And I think this paper is terrific. I really like this figure here when it demonstrated how they grouped their focus groups and how they looked at different themes: quality of life, information and consistency, and unreliable sources. We need to think about this, the old fake news situation. Lifestyle, increased screen time and reduced screen time outdoors. Cost is just important because we need to think about this cost over time. And at CERI, we have some funding to look at the cost of treatments and the cost to the state of not treating as well. So what do we need? Communication is the intervention here. So parents need clear explanation of risk, practical treatment options, honest discussion of concerns, and confidence in the treatment. So we need to think about bespoke treatments. In other words, we personalize recommendations. Visual aids are vital, and encourage questions and shared decision making. So let's look at these visual aids. A risk ladder will illustrate varying levels of myopia risk. Growth curves demonstrate the importance of early intervention measures. Comparison graphics, pictures, highlight the differences between healthy and myopic eyes, but also stories and visual stories. They can simplify complex concepts, and this will help and improve comprehension. And then we have to think about perceived risks and actual risks. This is huge. So we can, when we think about it here, parents can be concerned about possible risks with treatment, but the real risks are manageable and minor. And then if we think about the risk of not treating, that is fundamental. We need to think about that. So let's see what's happened over time. The evolution of parental perceptions is interesting here. So for the past decade, parental perceptions have shifted from viewing myopia as an inconvenience to a public health issue, and that, lifestyle plays a part here. However, awareness of causation has progressed faster than understanding of long-term risk. We need to think about this. We need to think about what parents don't understand, pathology, axial elongation, and all of that. So the take-home message is parents often underestimate risk. Even concerned parents may lack an understanding of pathology and management, and awareness and understanding are not the same thing. So really what we're looking at here is that we have to think about, I suppose what we can really take about from this is that the important message is that the uptake barriers are not just parental. Families are making decisions within healthcare systems, financial constraints, communication environments, and modern lifestyles that are increasingly complex. And successful myopia management requires not only evidence-based interventions, but evidence-based communication, trust, and realistic support. And I recommend, for more on this, I recommend you take a look at our paper here that was recently published in the Ophthalmologist that looks at understanding parental perceptions and barriers to myopia control uptake. And thank you so much for listening.
Dear colleagues, today I will present a sponsored lecture on the use of 0.01% atropine in myopia control. Here are my financial disclosures. As I mentioned, some of them are relevant to the topic of this presentation. Let me start with saying that controlling myopia is crucial for slowing progression and reducing the risk of future visual impairment. We know that slowing myopia progression by 1 diopter can significantly reduce the risk of vision-threatening conditions, including 60% increased risk of myopic macular degeneration, 30% increased risk of retinal detachment, over 20% increased risk of posterior subcapsular cataract, and 20% of increased risk of open-angle glaucoma. Atropine is a non-selective muscarinic acetylcholine antagonist. It inhibits myopia development in both humans and in animal models. In humans, atropine causes cycloplasia. However, mechanism whereby it slows myopia progression is not via paralyzing accommodation. 0.01% atropine became one of the most widely used treatments for myopia control globally after the ATOM2 trial. We know that atropine 0.01% resulted in minimal pupil dilation, slight loss of accommodation, and no near vision loss compared with higher doses. And among pediatric ophthalmologists globally, nearly 2/3 regularly prescribe this concentration of atropine. There are many studies on analyzing the effectiveness of and efficacy of 0.01% atropine. On the left side, we see clinical studies showing significant effect of atropine, and on the right side, studies showing a lack of atropine effect. As a matter of fact, there were 3 such studies, and we don't know why they were not able to show any effect. We hypothesized that it might be due to the inconsistencies in the formulation of atropine that might have led to differences in bioavailability and effectiveness. It was also shown in many studies, this is one of them, Atlas study from Singapore, long-term safety up to 20 years after treatment. We know that atropine works in a concentration-dependent manner. Based on the LAMP study, it was shown a clear concentration-dependent effect from 0.05% to 0.01%, with 0.05% yielding the highest treatment efficacy among these concentrations in Chinese children. And it was also confirmed in predominantly European population in MOSAIC trial. We also are quite aware about real and potential problems with compounded products. This is one of the studies that was published already 3 years ago and presented many of these problems of that the storage recommendation varied beyond use dates range from 7 to 175 days. Median pH of sample was 7.1. However, the range was between 5.5 to 7.8. And the median measured concentration relative to the prescribed concentration was 93%, and 25% of samples were under 90% minimum target concentration of 0.01%. This led to the, at first, positive opinion by European Medicine Agency for the product Regionia by Santen. It was, as you see, in March last year. And then approval by European Medicine Agency in June 2025 of this project. And this is the on-label atropine 0.01% available in Europe. In Poland, Polpharma company introduced to the Polish market another product named Miopia. It's a preservative-free multi-dose vial for 1 or 3 months therapy. So what is the present place of low-dose atropine? Well, some studies show that white ethnicity patients better response to this low concentration atropine. Such data come from CHAMP study that was predominantly white population, and also MOSAIC study based largely on white participants. It was also proposed that 0.01% atropine might be enough in older children, in slower progressors. Here we can see the comparison that myopia progression was comparable in a 6-year-old child receiving 0.5% atropine, 8-year-old being treated with 0.025% atropine, and 10-year-old receiving 0.01% atropine. So older children are more they have more acceptable tolerance of the accommodation loss from 0.01% atropine compared with higher concentrations. Then another very important topic is the rebound effect and tapering strategy. So ATEM2 study showed that the cessation of 0.1% and 0.5% atropine led to a greater myopic rebound and faster overall myopia progression compared to 0.01% atropine over 3 years. And 3-year LAMP study showed the previously treated 0.05% group had a faster axial length elongation than the 0.01% group over 12 months. So tapering strategy may be beneficial during treatment cessation, and 0.01% atropine could reduce the rebound effect. Another potential approach to use the low-dose atropine is a combination therapy, multimodal myopia management, incorporating pharmacological, optical, and behavioral intervention may provide complementary benefits in slowing myopia progression. adding low-dose atropine to establish optical interventions may enhance control of myopia progression, and for patients who show insufficient response to low-dose atropine, monotherapy combination with an appropriate optical intervention or other myopia control therapy may further improve treatment outcomes. There are already many studies showing benefits of the combination therapy. Here are most recent studies based on the combination between atropine 0.01% and DIMS technology. As you see, these studies come from Asia, one from Italy, from shown as Europe. Then we have no time to discuss the studies individually, but since it is recorded talk, anybody can check it in detail later. Here we see studies showing benefits of using combination of 0.01% and HALT technology, again coming from Asia. And here studies, this is one study, as a matter of fact, with a 3-year follow-up from US, showing a combination between low-dose atropine and contact lenses. Then we have quite a lot of studies on the combination with Auto-K, mostly from China, as you can see it here and here and here. I would like to say a few words about the phase 3 STAR study that was published just recently. It is currently the largest and longest randomized vehicle-controlled low-dose atropine study in a predominantly white population. Results show that atropine 0.01% significantly decreased the rate of myopia progression versus vehicle at month 24 in children with myopia. However, treatment with atropine did not significantly slow axial elongation after 2 years of treatment. Interestingly, sub-analysis showed a sustained effect after 2 years in the fast progressor subgroup. And at the end, I would like to share the results of our meta-analysis that was just recently published in British Journal of Ophthalmology that concluded that atropine at all doses effectively reduces the progression of myopia measured by both spherical equivalent and axial elongation in a dose-dependent manner in children aged 4 to 16 years. East Asian children showed greater reduction in both spherical equivalent and axial length compared with South Asian and White European children. East Asian children also experienced a greater dilatation of the pupils in photopic lighting conditions compared with White European counterparts. Thank you so much for your kind attention. Dear colleagues, we start the discussion of the session 2. We have our speakers. I would like to thank all the speakers for this session, for very interesting, very educative presentations. And we are open for the questions from the audience. So if anybody wants to ask any question, please put it on the chat. I just maybe start with sharing the information that we have 460 registered attendees to the meeting. In the meantime, waiting for the questions from the audience, I have a question to our speakers to start the discussion. What we are currently missing in myopia control? What is you think the most important? What shall we develop? I mean, or work on prevention, standards, new treatment approaches. This is an open question for anybody who want to discuss it.
I can just jump in. I think we need to know more about the mechanisms of myopia development and progression. And I think we have research on myopia treatments for many years, for example, atropine and ortho-K, but we don't know well the mechanism. And I think that's one of the things that we need to uncover. And I think that will help to develop new treatments or treatments that are more effective for myopia.
Thank you, Carla. So for you, mechanism is number one, most important. The question, is it, let's say, obtainable? Because we have been working on this subject for the last 20 years with not much results. Okay, who is the next? Haken, please.
Well, I think the mechanism is point two, because I think it will be very long till we really understand what happened in the retina and everything on. So I'm just happy that we have a treatment for the children before we start to search the mechanism and then find the treatment. So we are really in the lucky place that we have a treatment. I think we have to establish standards like our treatment goals and how we define success. And I think this is what I try to establish with all you together.
Thank you. Sofra, please.
I think the environment is key. I think this changing environment and the way children are living their lives has exacerbated the situation. So I think we need to have a greater understanding of the lighting environment and the dioptric environment and how people spend their time. And maybe it's too big a problem to land on the shoulders of just clinicians and also on parents. I think we need to look at, I think one of the points you mentioned earlier about understanding what's happening in the school day, how much daylight can we introduce into the school day, how can we maybe adjust the school day for young children so that we can factor in that daylight time. I think the public health aspect of getting that message out there about the environment for me, is one of the key things. Yeah.
Thank you. Elena, please.
I think that we have to focus on pre-myopes, especially high-risk pre-myopes, and to do the cycloplegic refraction and to know what about hyperopic reserve. And when we identified high-risk pre-myope, then we have and we can intervene with outdoor time and exposure, because that's the hardest and the most important evidence-based. Spending outdoor time more than 2 years, and maybe to change the school system if it's possible, to put 40 to 80 minutes outdoor time exposure during the school. I think the prevention is the key for us parents who has young children, and also for clinicians. But also I agree that mechanism is very important, but maybe it took years to find that mechanism, and I think the quickest way is to find the pre-myopes.
Thank you. Beata, please.
Yes, I absolutely agree with Jelena. So we are a European council, so we should do something in European level, a regulation. So maybe you have to think about in a higher level, political level, to do some regulation.
Anybody else? Yes, Olaf, please.
Yes, there are plenty of factors.
Just to introduce you, I mean, Olaf, just to introduce you, because you have the information Omistaja, but this is Professor Olaf Parsinen, not Omistaja. Just to
yes, it's in Finnish. Yes. It's owner.
Owner.
Yes, okay. I'm Olavi Parsinen. I'm a myopia researcher. And retired, but still continuing myopia research. But plenty of factors are missing. For example, if speaking about those contact uses using myopia treatment, spectacles or contact lenses, for example, by using also outdoors dose, because all the animal experiments has been done preventing distant vision by, for example, using outdoors when just being without glasses outdoors, it's preventing myopia. One question. And then about using axial length as a measure, it's quite crude measure to use it without knowing all the other optical elements which are influencing on the refraction. There is a anter-chamber depth, lens power, distance between them, and so on. So axial length compared with corneal refraction, it's better using corneal refraction width, but it's still quite crude measure.
Thank you, Kolafi. We have a question. As a matter of fact, this is the question from our panel member. It is a question from Trina to Carla. I will read it. As a clinician, I'm uncertain about using low-level red light therapy. It sure seems to be very effective, but after Austria showed that devices surpass safety thresholds for retinal toxicity, what is your approach? Carla, so
yeah, I think there was an earlier comment as well on the chat on the same impression. So as I showed on my presentation, I talked about effectiveness, but also talked about adverse events. And I've showed some images on structural changes that have been reported in some cases. From what we know so far, because we only have data from 3 years. I think the longest RCT so far shows 3 years data. Those case reports, all those events are quite rare. And when the treatment is stopped, the structural changes seem to be reverted. So that's what we know so far in terms of results of the red light treatment. And of course, I'm also uncertain regarding treatment, but it seems to be highly effective. And again, I would come back to my question or to my thought about mechanism, because although we have treatments and we know that we can control progression up to a certain level, what we don't know so far is if we are going to prevent pathological myopia. So we don't know the endpoint now. We will know in future when we have these children growing up, and that's what is really important here, to understand if we are able to prevent this severe disease at the end. So I do think the light-based therapies may have a role, but of course we need more research to understand the toxicity levels, and I don't think we have the data right now.
and
Karen
if I
has a question.
add something on that, to Carla, I would recommend not to use unsafety devices. I mean, that surpass safety thresholds. I mean, at the European Union level, there is one device that is certified by the, let's say, Australian company that was shown to be safe. So we should use, obviously, in any sort of medicine, including of different ophthalmology subfields, we should not use unsafety devices. It is always possible that some manufacturers, they will produce unsafety devices, so they must pass the safety, let's say, norms. Hakan, please.
It was just the question for, do you think it could work also in closed eyes when you do the red light therapy? Because we know when we're doing the photobiomodulation, patients with AMD, they close their eyes in the red light wavelengths.
I'm not sure. I think it's an interesting question to do some research on it. I never thought about it. Maybe I'm not sure. I think we will need to to know more. I think one of the other questions that is being researched as well is whether it is a treatment that could be effective for pathological myopia. And I think there is a trial ongoing, and we will have some answers soon. But on your question, I'm not sure. I will do some research about it.
Thank you. We have a question from the audience. What dose of atropine should be the starting one in a 6-7-year-old child? Since I spoke about atropine, I can start with. I mean, of course, it's open for everybody. I would start with the, let's say, relatively high dose. From the low dose range, so at least 0.05%, because I think that in such a young children we should be aggressive as much as possible, and probably also add optical method, so as much as what is available to stop progression. I mean, this is my approach. Anybody would like to share?
I can comment on that.
Yes, please, Trina.
I would do exactly the same. So 0.05% would be my start dose.
Thank you.
But I would probably start with the spectacles and then add the atropine, or yeah, I don't know if I would start both right away, but that is definitely something that we need to look into, which children we need to start combination therapy in right away. And there was a very nice talk about that and some previously in this
Thank you. I have one more question to the panel. After listening to the lecture of Professor Resnikov, I have a question. Should we recognize myopia as a public health priority in Europe, having in mind the epidemiology data that were nicely presented by our colleagues? So what do you think about that? Again, open question. Who would like to address it? Start with.
Yes, if I can.
Please.
In Finland, there are perhaps glaucoma is priority, cataract. But of course, myopia is causing.
I think
it's connected with those.
I think in patients between 40 and 60, the most relevant risk factor is myopia for legal blindness. So I think it makes really sense to put it in a higher level. Not for the older ones, but for the younger ones.
Yeah. Carla, please.
I think we need, in Europe especially, we need to start measure more and have the data and information. And as we have shown in many of these meta-analyses from the prevalence in Europe, the data is really heterogeneous. So the methods from the research studies that have been published are different, using different protocols. And I think we need to work on that and to measure well the situation in Europe, so then we can decide and have plans about how to do and how to manage myopia in Europe.
Thank you. Siofra, please.
I think it is ultimately a public health issue. We've actually missed the boat for a huge cohort of the population. We're too late with the treatments. We have a large bulk of the community who are moving through with higher levels of myopia, and we need to plan for how we address those who will be visually impaired. We're too late for. And we've been doing some research on that in Dublin, where we have been looking at, let's say, the prevalence of retinal detachments or different issues that are associated with myopia. And there's been really good papers, data from the late 1990s, early 2000s, and we're working on one now. And the Scots did as well. In Scotland, they found that you have this increasing prevalence of retinal diseases or retinal detachment and other things associated with the increasing prevalence of myopia. So I think we need to be cognizant of the fact that in Europe, as it's not just Asia, it's not just South Korea, but in Europe we do have a problem, and we need to plan for that and focus our resources on those who we're too late for with the treatments, and how do we support them, and how do we make sure that our public health systems have the finances in place to address it. So I think it is fundamentally a public health issue, and hopefully I'll be alive in 20, 30 years to see it. But at the same time, I think we do, by 2040, 2050, we will be in a situation where we should have taken this a bit more seriously. But early, yes, we have to be very careful about how we collect data, and we have some really good protocols around that already. But I think we can't wait really to collect perfect data. We have a lot of data already, and we can see the trajectories. So I think very much so. I agree with Serge. This is a public health issue, to be sure.
Thank you. Christina, please.
We are really sure that the problem is also in Europe, because we agree with Carla that we have different approaches in the studies that we make. But the thing is that since 2016 in Spain, we have followed the same methodology in the study, and we have reached that in 2016 we have the 16% of children with myopia, and today we have the 21. So I think that we have a problem, and we need to act before having a very big problem. So I think that we need to do something, and I think that we are in the right place to do it. So
thank you. And all of you, raise your hand for a moment. I'm not sure if you want to say something. Yes, please.
Yes, the problem is different in different countries. In Asian countries where almost everyone is myopic, that's of course the main problem, public health problem there. But if the prevalence is 10, 20%, then it's perhaps not in that kind of population. It's not the main problem. It's problem in every way, but not perhaps the main problem.
Thank you. I think that we need to increase the let's say evidence and the information we have, because what comes from the studies that were recently published, it shows at first disproportions between some European countries. We do not understand really why they come from, where they come from, and finally, still for many regions in Europe, we have no data, or very small number of evidence. So we need to accumulate more knowledge, and probably our group, I mean European Myopia Network, can help with that. We need probably to develop potentially inexpensive way because unfortunately epidemiological studies are complicated and expensive. This is the barrier. So if we could develop a protocol for something that is that overcome this limitation somehow, that and try to propagate it among our colleagues, and we also try to conduct such as studies according to the same protocol. Maybe the reliability of the data would be higher. So this is my idea. Now we need to finish the conference. I would like to thank you so much for excellent presentations, very educative discussion. And now let me say a few words to all of the attendees. Thank you for being with us today. Again, thanks to all of the speakers, not only to speakers of the session 2, but also session 1. Special thanks to Professor Serge Resnikov for preparing his excellent introductory lecture. And again, I would like to remind that the meeting was organized together with the European Myopia Network. Everybody who is interested in supporting, being a member, can join us by just registering at the website and being involved in our activities. So thank you so much, and See you next time.
Thank you.
Thank you.
Thank you. Thank you. Bye.
Bye bye.
Bye.